They have navigation. They have BK ultrasound, that is Ferrari of ultrasound. That I'm very happy about this. And they have lots of instruments, especially Codman, microsys, everything for microneurosurgery. So I'm very happy.
Excellent.
And I brought with me obviously the Yashargil armrest that I bought in Turkey 6 months ago. So I'm very happy. Everybody asked me, "What's it? What's this?" I know you. I will let you know what is this. Anyway, and I did my first 2 cases. Baby, 3 millimeters. It was challenging for me, Professor. MCA aneurysm, but really, really small. But it was good. And falcotentorial meningioma, the first elective cases, the aneurysm was ruptured. And the second one was a falcotentorial meningioma. It was in a very young guy, but I discharged a patient on the 3rd pod, so I was very happy. Without deficits, was very good. And now today, I just saw they sent me an MRI of temporal mesial, probably the net right side, to do transylvian amygdaloid hipocampectomy, basically. But I will do it after Christmas because I want good anesthesiologists and but every day, let me tell you, and then I stop me every day. I remember your words that are giving me very strong during this moment. Don't give up. Go ahead, because it could be really stressful at the beginning. So yeah, thank you so much once again for your precious and golden advices.
Good. You're gonna do a great job, no doubt.
Yeah. I want to start to implement, and then we can talk about a lot of things, because you know very well that we have an Italian cases, me and Giancarlo, that I have to show to your attention. So now I'm taking care about everything, because just in case you want to come, I want to let you find the good places. That's why. Thank you. Okay, Mehmet. No, 5 minutes more. Professor Pecker.
We have 5 more minutes, yes.
Yeah. Professor Pecker is joining us. Good morning, Professor Pecker. Can you hear us?
Yes, I do hear you.
Yeah. Good morning.
Nice to see you.
Welcome.
Nice to see you. Welcome.
Thank you, Dr. Zileli. Thank you.
Good morning.
Dr. Ali Krish is with us.
Professor Krish is here. We are waiting for Professor Gardner.
Gardner did not show up yet.
About the order of the speakers, Mehmet, if you agree, I would start with Professor Krish, and then probably Professor Gardner and Professor Pecker, if you agree, or if you want to invert the order, but I would start with Professor Krish.
We have placed Selçuk Peker after
Professor Krish. Okay.
Yes.
Okay. Sorry, I didn't check.
Now, hopefully, I'll try to stay till the end of the session, but we do have a ruptured anterior communicating artery aneurysm. But if they got ready, I may have to
sure.
go earlier, but I hope to stay until the end. Our winter here is a seasonal cause of brain bleeds and aneurysm rupture.
Really?
Yeah, no doubt. Slows down in the summer and picks up around this time.
We have the same idea everywhere, but probably nobody definitively demonstrates this correlation between the rupture and There was a study, to the best of my knowledge, of NASA or something similar, but it was not conclusive. This is what they told me one time.
Yeah, there is a group that looked at it from England.
England.
Yeah, about the difference. I remember in one meeting that they did not find a difference between the winter and the summer.
And summer.
But when he finished, I joked with him and I said, the weather is not different anyway between winter and summer in London. It's the same.
Yeah.
You wake up, it's sunny and suddenly it's raining.
Yeah.
Now, where you are, Sabino, you don't have much of a winter.
No, not at all, Professor. Here it's today is 16 Celsius degrees. It's almost summer. Yeah, you need sunglasses here. Really. It's amazing place from this point of view. Yeah.
Yeah, maybe I should retire there.
Yeah. Yeah.
Dr. Regunat, Regunat is with us.
Can you hear me?
Who is the other moderator? Yeah, we hear you.
The line is very bad. I'm just trying to go. I'm still in Cairo. The line is very bad, so just give me a second.
Okay, this is fine. We didn't start yet. We will have one more minute to start.
Okay, thank you.
There are lots of participants that should attend the meeting because lots of people are texting me and connecting, and it will be very good session. Very happy. Professor Gardner is here. He's joining us.
Yes, he just arrived.
Hello, Paul. Can you hear me?
Now I think.
Yeah, it wouldn't let me unmute, but now I can. Yeah.
Yeah, perfect.
Paul, you can unmute yourself?
I did now. It wouldn't let me at first, but now I could, yeah.
Hi, welcome. How are you?
Thank you. Great. Good to see you.
Good morning, Paul.
Morning. Hey, Ali. How are you doing?
Good.
It's early where you are. It's relatively early here, so.
Early. But, our life is a jet lag, so it shouldn't be a problem.
That's right.
I think we can start. I will just tell that this is our 15th WFNS Education Online Symposia. This will be 1.5 hour duration on the management of craniopharyngiomas. And just after that, we will discuss the management of degenerative spinal disorders, and we will also discuss it will be an interesting meeting, the unnecessary usage of implants in spine surgery. So then I give the moderatorship to Dr. Sabino Lucy and Regunat Kandasamy, and I welcome all the speakers and all the participants.
Thank you, everybody. Can you hear me? Can you hear me? Okay.
Yeah, we can hear you.
Thank you, everybody. It's a big honor and pleasure for me to be here in front of all these giants. As Professor Zileli already anticipated, this is the WFNS Education and Training Committee that decided to organize this session. And this session, this educational symposium, the educational symposium number 15. So we had lots of symposia here that are very educative, especially for young neurosurgeons. And today the topic was decided to be management of craniopharyngiomas. Craniopharyngiomas represent one of the most controversial yet fascinating challenges in neurosurgery. And these benign tumors, often arousing at the level of the cellular and supracellular region, present a complex interplay between the surgical ambition and challenging and patient safety. And we want to stress also that the delicate balance between achieving maximal safe anatomical resection and preserving critical neurovascular function is the key of this kind of surgery. So we have three world-renowned speakers today. Professor Ali Krish, that requires no presentation, is one of the most skilled world-renowned neurosurgeons all over the world, especially in terms of neurovascular skull-base surgeon. And is director of the Arkansas Neuroscience Institute, Little Rock, Arkansas, USA. And he will talk about the overall management of craniopharyngiomas in terms especially highlighting the radical versus subtotal resection of our craniopharyngioma. And then we'll leave the stage to Professor Selçuk Peker, head of neurosurgery department of Koç University Hospital, Istanbul, Turkey. And he will talk us about optimal timing and the role of stereotactic radiosurgery, stereotactic radiotherapy. And then Professor Paul Gardner, this Peter Giannetta Professor, Neurosurgical Co-Director of Center for Cranial-Based Surgery and Pituitary Center of Excellence, Pittsburgh, USA. That the topic of his lecture will be management of recurrence and surgery, radiosurgery, or systemic therapy. Okay, I leave you the stage to Professor Krish. That is a big honor for us to have you here, and thank you so much for having joined us.
Thank you, Sabino, and thank you, Mehmet, Dr. Zileli, for the opportunity. Let me share my screen. Can you see my screen?
Yes, Professor, perfectly.
Okay. All right. Well, thank you again for the opportunity. Craniopharyngioma is one of a dear pathology to me because of the potential that can be achieved and the unfortunate trend that has over the years built up to where we're building up a lot of patients to the extent of having a catastrophic outcome for a benign disease. Before I start, I have to always give credit. Whatever we do goes to the people we learn from. And I have great teachers and pioneers in the field who have been even colleagues, and I'm lucky to have had them as partners in my job as well. Dr. Al-Mefti, the late Dr. De Oliveira, and obviously we're all under the umbrella of Professor Yazagil's School of Thought, Microneurosurgery. Now, to approach any disease and how to handle it, one of the most important things is to define the goal of the treatment. And if you change the goal and to not what's achievable, then you're going to end up with less achievement, obviously. And craniopharyngioma is a good example. So how to achieve the goal in the majority of the patients is what counts. There are different treatment options, but they don't address every single case. You have to go into any disease, especially if it's a curable disease, which is benign, and you have to set a very high goal, which is to get the highest outcome in the highest number of patients. And the treatment plan has to be tailored to achieve this goal. You cannot start with less than the highest goal achievable for those patients. So what are the causes in this case for the problems that we have seen and the reasons why failures occur? Now, number one, there's no in-depth knowledge of the anatomy of that region, and you end up, if you go ill-prepared, you're not going to finish the job. And if you go ill-prepared, you're going to cause morbidity. And if you end up with these outcomes, obviously you're going to shy away from it. And then what is usually the blame on? It's the blame not on your ill-preparedness, you blame the disease. It's like when you go in, I always say there is no difficult case. A difficult case to me is a glioblastoma involving the internal capsule because you already lost the battle. But if you go to a disease like craniopharyngioma and you are ill-prepared, then you're going to cause damage and you're going to call it a difficult case. And it's lack of knowledge that gives you that outcome. The other thing is no in-depth knowledge of the pathologic anatomy. We have to know how these tumors grow, where did they grow, and what different types. For example, it's being commonly used whether it's a patient, if the tumor is retrochiasmatic or prechiasmatic. I can tell you now, this is total nonsense because it has nothing to do with the anatomy of the pathology, and I'll address that. But if we decide by classifying things, which I have done even myself at one time because I learned it, then we're going to do bad outcomes because you're tailoring your treatment based on the wrong anatomy. And then with that given, and then if you don't have the adequate approach that will get to the whole corners of the disease, then you're going to end up leaving tumor and you're going to accept a suboptimal condition. So in that case, what happened, the trend is with this, we had wrong knowledge of the disease with a combination of wrong anatomy. We end up changing the goals of the treatment because we could not achieve the highest goals possible. And then we go preach it. And this is the trend. Now, when you look at the books, which has any chapter on craniopharyngioma, you have a small paragraph about the importance of trying to get surgical resection. And this is usually the best option if you can achieve it. But, and then you have 3 pages, which really, when you finish reading the chapter, you get the impression that this is impossible. Just forget about removing it and just plan for a partial resection or accept it. So then these are what comes. You hear people say this is impossible, this is not true, if you can remove it all, but if I do not believe it, it's unbelievable. If I cannot do it, no one can do it, and so on. So you want to change on that, especially for the young people listening. You want to start with, that's maybe interesting, let me look into it. I want to see how they do it, or if somebody has expertise, and then I want to learn it, and how can I improve it, because we need more people to be doing it, because the larger the number of people doing it. So if you look at what is described advances in the management of craniopharyngioma, there is always a similar trend in those cases. There is always a loss of the goal to a lower level and accepting much less ability, to the extent that now we end up, and like a lot of patients coming to deal with resectable tumors, now I have a cardiologist, and I'll show you his little video, what he said. He was told that you should not remove the tumor. You should aspire to getting a biopsy, and then if it has the BRAF MEK mutation, then we can give you medication. And if you look at the even recently in the New England Journal of Medicine, it's not helping, you know. And there's a good number of patients who you have to keep in mind, this is a chemotherapeutic agent that you get, which has its own side effects, and we undermine it because we assume the other alternatives are terrible. And even when you look at this, what's described as aggressive surgery based on atomic classification, it goes back to the same thing, the intracellular type, prechiasmatic, retrochiasmatic, intra-third ventricular. This is the closest article to what the reality is, but there is no prechiasmatic and retrochiasmatic, and I'll show what that means. And the impression you get when you read an article about surgery of craniopharyngiomas is best exampled here. It says, although only gross tumor resection has been proven to provide cure, like I said before, it starts with the correct sentence, the accompanying surgical hazard is substantial. So you already turn off somebody who is reading it, and you advocate less aggressive operations because they call it damaging heroic measures and so forth. So when somebody Googles craniopharyngioma, if you look at it as what is life expectancy of someone with craniopharyngiomas? Craniopharyngiomas are morbid tumors that significantly reduce patients' quality of life. The lifelong burden of endocrine, visual, hypothalamic, limbic dysfunction can have disastrous consequences for the physical and psychosocial health of patients. That's what patients get to read when they look at for craniopharyngioma. Now, let me give you this exercise. Take craniopharyngioma here and put glioblastoma on it. It is like reading a malignant disease. That's really wrong. So we have to do better. We cannot give up. Otherwise, this is what's becoming the standard. Partial resection becomes a standard. You add radiation, you call it hybrid treatment. And this applies to a lot of things that we do. And that has to be a change. Otherwise, we have lowered the bar significantly, and we keep changing, moving the goal. And in that case, who's suffering really is the patient, and also our specialty, because eventually you will become the person who you just need to do a biopsy to be treated by somebody else and accept that this is like a cancer in a way. So the focus nowadays is treatment of the patients today, while tomorrow's patient is forgotten. And worse than that, if we keep this trend, less people are going to do better surgery. And in the future, there will be no experts to treat the patients tomorrow. And just imagine if this is your loved one, and you're looking for somebody to help. So the problem is those who do not know, they are talking. Those who know do not speak. And that has to change, And to change it, we have to look at what was achieved in our abilities in the yesterday and what should achieve today, and how can we achieve more for tomorrow. And that's what has to be. Because at this moment, what's the status? There is a lot of discussions. The podium is being stolen by those who are presenting progress when it is regression. And it's portrayed as progress. And that's not right. And we have to change it. So when we go back to the question, like Einstein said, we have to go back and ask the same question, because the answer today is different than yesterday, and we cannot give up on these patients. And how do we achieve that? By knowledge of the surgical anatomy and the pathologic anatomy. So microneurosurgery provides the most curable outcome. Let's go back to the future. That's how it should be approached, because cure is a big thing for patients, and we cannot underestimate it. Just imagine yourself in their position, and you have a curable disease that ends up becoming like a malignant entity, and that's not good. So when it comes down to it, you get a patients like this with these tumors. They are being mishandled, and this is an example of those cases that I'll present. And there are two types. This type is really intraventricular anatomically, and this type is extraventricular. And that's all what you need to do. Now you need to study the anatomy and then tailor it based on these two approaches in a way. And then you will plan the correct approach for this surgery, and I will allude to it. Otherwise, like in this case, this is the tumor of this patient who is a pediatric cardiologist, and he's very knowledgeable, start reading. By the time he came to me, he said, I trust your surgery, so I just want you to do partial resection and get the diagnosis. So if it's papillary, we can treat it.
Josh Daly.
And that's what
I'm a
he said.
pediatric cardiologist from Little Rock, Arkansas.
Can you hear
About
it?
2.5 years ago, I had a brain MRI, which demonstrated a 2 by 2 centimeter avidly enhancing supracellular mass consistent with a craniopharyngioma. The initial recommendation was that due to the high risk of panhypopituitarism and other operative complications, I should have a biopsy, and then the likely medical treatment with BRAF and MEK inhibition.
So he was told, that's what he was told. You know, there's a lot of complications, don't do anything about it, just take a biopsy and get treatment with chemotherapy. Fortunately, he ended up coming and getting operated.
I ultimately proceeded with a complete resection and had a great result with no diabetes insipidus and no additional pituitary dysfunction. I'm now completely back to normal, fully engaged father with 4 young children and a busy cardiologist. I'll be forever grateful to him.
And why he wanted to present this video, he said, you need to put me on your lectures because it is not fair the way what I went through with going around. And he went to the most, known places to get the advice. He was capable, and he found out that all the advice tells him to live with the tumor. So this is an article I published, and I'm telling you, don't read it. It's wrong because of the way it was classified at that time with prechiasmatic, retrochiasmatic and stuff. It is wrong. So the train, or the new train, has already moved, so you have to catch up with it. Craniopharyngioma has to go back to the fact that this is a resectable, curable disease, and that should be the first goal, and we have approaches that can be done. You cannot go with an approach that cannot treat the overall majority of them, hoping that it will work. This is incorrect, and the goal has to change. It's not only to get a good-looking MRI post-op that looks like you removed it, because I can go in and deflate cysts and make it look like that. So where is these tumors? Like I said, there are 2 types of tumors, one intraventricular, one extraventricular, and you have to understand them. And what does that mean? And since we have changed our policy, and I'll present the results of our 44 cases and how we approach it. This is a case which starts from the pituitary stalk, and it grows and fungates out. And it's all extraventricular. There is nothing in the ventricle. And you have to treat it in this way. It looks like it may be in the ventricle, but it's not. And this is an example of it. They fungate out. They start in the pituitary stalk. And if you understand all this, then you can get this result. This is a 15-year-old who had failure of puberty in a way. And that's how you can get these back to the normal functions in this way. You can implode the tumor from where it exploded, but you have to have the right approach and understanding of the anatomy. So this is how I would advise that we look at it. There are these 2 which are extraventricular, and this is intraventricular, which arises from the inner part of the stalk in the 3rd ventricle. And these 2, this is less common, the distal one. This is the one that grows in the sella. This can be removed transsphenoidally or endoscopically. You can get a total resection in these cases. But once they start going out, then that's where you increase the risk unless you do the right approach to get those. So this is the more common ones, which are usually arising from the stalk. They can grow down into the sella, they can grow up in the prechiasmatic area, or they can grow in the, like in this case, you have one cyst, which is similar to what this is. This used to be called prechiasmatic. No, this is the same tumor. The extraventricular starts from the stalk. Now, when it starts growing further with multiple cysts, and then it becomes of this type, and if this cyst grows into the ventricle, and this grows inside the floor of the hypothalamus from the outside, and this is extraventricular. It may look intraventricular, and these are the cases where most injury occurs because there are adhesions, which are gliotic tissue around the tumor in the hypothalamic region and the mammillary body area. And that's where, if you don't know how to dissect this well, you can cause injury. And then when they grow further, they can grow into these areas, and they can, like in this example, for example, they have multiple cystic components. But again, if you know the anatomy, which is what I show like in this picture. This is, you know, where these tumors grow. You need the approach like in this case, which will show you where these tumors. This is the optic nerve on the right side, the A1, and this is the optic tract. And these are the tumors growing in different cysts. And then they can bulge into the ventricle like here, but they're not really growing in the ventricle compared to other ones. So that's the view you can get when they are bigger. And the approach has to get all these windows, otherwise you will not be able to remove them. And you have to go lateral. This is why endoscopic is not going to be enough in a lot of these cases. And you're going to end up leaving tumor behind. You may get a nice looking MRI, but it's not. In the intraventricular ones, these are the ones which grow inside the ventricle, not from outside like the others. And those have to be approached the right way. And the right way is to go through the tuberal area. This is the area that you do the third ventriculostomy. And the tumor usually allows you to go in because it bulges out and it prepares the field, and I'll show you the approach for that. So this is the view of the approach for the intraventricular one. That's a pituitary stalk. You go posterior to it and a little lateral, and usually the tumor is bulging in this area, and that's the entry point, and this is the safest entry point to get to it. So this is what we published before. You can, please don't read this article. And this is the pterional approach with a wide exposure. This is not enough. You have to have a wider approach that we use in this case that will allow you to get to this area in a wide area. So the window that we go is in the pretemporal space, and then you unlock all this medial area. You have to be prepared to mobilize the third nerve because this will give you a wide window away from all the perforators. And this is the window that we use. You can see this was, and when I was doing the basilar aneurysms with the approach we did, I found out this is the best approach for craniopharyngiomas because you can get all these cysts and you can see from suprasellar, prechiasmatic, retrochiasmatic, all the way to the posterior fossa. And if the tumor goes between the carotid and the optic nerve and goes bulging into the frontal lobe, you can see the whole thing at the same time. And that's where a tumor like this will end up with this view. The only thing left you can see is a small piece that was attached to the perforators. And this is when I say in my patients, we left a small piece. That's what it means. We coagulated and leave it in situ and follow it. And this is when, if anything in the future that you consider radiation, that's when we would consider it. But a tumor like this can be resected, like in this tumor, or this one with multiple cysts. It gets up the same window that we approach. And this is the tumor that goes beyond the limits. It goes out into the frontal lobe and into the sylvium fissure sometimes. Or like this one, this young patient. And you can see how it looks intraoperatively. You can see the tumor in its cystic components in the prechiasmatic area. You remove this part, and then you can see the part which was between the optic nerve and the carotid that went into the frontal lobe. And you have to preserve the whole cyst to bring it down in one piece. Otherwise, you cannot just hope that you can fragment it and try to leave a piece and then do an MRI and say, I have radically resected. No, you have to be able. And then once you finish all this space up there, you just come down and you see how the window allows you to look from all different angles. I can see from here, then you can see up to the third ventricle floor. And by the time you finish, you reestablish the anatomy fully. And that's how the MRI looks. And this is down the road 2 to 3 years later. The last MRI looks clean. And these patients are cured. Now, when it comes to the ventricular ones, you have to be careful. This one is extraventricular, while this one is intraventricular. You may look at it and say, well, they look the same. No, they don't look. Look at the third ventricle here. There is no third ventricle. Look at the third ventricle here. It's there. It's pushed up. This tumor gets attached to the undersurface of the ventricle at the hypothalamic region. These are the ones that you cause injury to the hypothalamus because you are dissecting it and injuring it. And if you don't know the anatomy of it, and you don't have the wide exposure, you're going to end up with trouble. And you can see the difference when put next to each other. You have to have this very deep understanding of them. And that's the post-op for that case, while in this case, this is the post-op. And you can see how the ventricle was reestablished. On the other one, the ventricle was already there from before. It was already there. So, and those details, if you don't understand them, you're not going to be able to remove them. That's why this becomes a major challenge. And this is also an intraventricular one, which drapes down over the basilar artery. And for these cases, you really need that approach that I showed, because you have to see all the different aspects of the tumor. And this was a firm one. And this is the window that you enter from. This is the optic nerve, optic chiasm. This is where the tumor is, and it bulges down because it arises behind the pituitary stalk. So that's the approach that I show the picture from. And this is an example. That's the view intra-op. This is the PCOM, and this is attachment to the posterior cerebral. You can cut PCOM in a perforator-free zone, like in this case. And this is the bulge of the tumor. But notice there is no any perforators in the field. This is the third nerve that has been skeletonized, and the wide area from the pretemporal space, and that's the approach that you get into the tuberal area. And then once you get there, that's another view of the anatomy in a cadaver. Then once you get to this view, you will look down, and then you open the safest part and enter it and gradually create the space. And this is the thin area of the tuberal area, and you get to the tumor, and you stay within the tumor, and you start removing it, just like when you remove a pituitary adenoma, when you have a window that you can kind of contain it circumferentially. And then by the time you get to a certain level, then you will get it, and you can see the hypothalamic wall, and it's usually easy to differentiate. These intraventricular ones, in my experience, they're never really stuck to them. The one that's stuck to the hypothalamus is the extraventricular ones. And then towards the end, then all what you do is you disconnect it from where it's attached to the stalk. See, the stalk is in this area, and you take the last part of it, and you preserve the stalk connection. And these patients, I usually tell them there's a high chance you're like this pediatric cardiologist that there will be preservation. So this is the pre-op, this is the post-op, this is the patient, and these patients are cured, or the closest to a cure. And that's how our goal should be. So even a large tumor like this, and again, the same approach, and this is the window we use, pretemporal, this is the middle fossa exposed, that's the entry point, and that's the view you see, the tumor exposed, and that's the window that we open to remove it. And this is at the end, the whole bulge is gone. This is the basilar artery, this is the P1, the stalk, and this is the carotid optic nerve. And this patient had a very unfavorable anatomy, and that's something you have to keep in mind. Not all patients have a wide incisura, and you have to do the approach that will overcome difficulties with anatomy. You cannot go in hoping that the operation will be easy. You go in to make the operation easy. And if you don't know the best approach to achieve the most radical resection, you're not going to achieve this resection and getting this outcome in this patient. And so we have two types, and you have to understand them. You have to know how to approach them to get the best outcome. I'll finalize with those points. This is 44 cases. The first time around, I had at presentation 39 were tumors which were de novo sent to me, and 511. This is since we've changed our policy and we use this approach. And all of them are big. You can see this is unfortunately, because we're popular with this now, we get only the ugly ones. And this is the average size is 3 centimeters. And cures in de novo cases from first surgery is 84.6%. We cannot underestimate what we can do. We have to go back to this. And if I could not, or for some reason something comes up, I usually tell the patients in the next 6 months, I may operate again. because if something shows up that I missed, usually it's more common with those multicystic ones, then I will go back. And in these cases, we had recurrences in 6 patients, and all of them had additional surgery. It was only left in 4 patients in those. So the mortality is very low for these patients if you catch them well. This is the problem with these cases. They're sick, they haven't been moving, unfortunately, they have the tumor for a long period of time, they've been neglected. By the time they come to you, they are a medical mess. You have to catch them early. There's nothing about waiting to see how things are. Craniopharyngioma, the minute you catch it, get it out of the way. And my problem was with the medical issues that these patients have. So in conclusion, especially for the young, please be informed and not misinformed, because it is not right what's being done to these patients. And plan to persist. This idea of steep learning curve to learn certain approaches, this is nonsense. We have to stop talking about steep learning. My life is a learning curve. We have to dedicate ourselves to these patients. Just imagine if these were your family members. And this idea about life balance, sacrificing your family and divorce, nobody divorces because of sacrificing to your patients. You divorce for other reasons. Please, let's go back to what we should do. Let's set our aims very high. Let's master the basics in anatomy, the principles behind the approaches, know the anatomy of the pathology. We have to know it so we know what we can do. Find good teachers who are passionate, not giving up on what they do, and plan long term. So this is not who is right, but what is right. And who decides it? I am not telling you I'm deciding it. Something else decided. This decides it. What is this? And like an example of cavernous sinus meningiomas, why we're able to remove them now? Because we know the anatomy. And that's what we do. The anatomy should decide what is right, the anatomy of the normal and the anatomy of the pathology. With that, I would like to show that Dr. Sabino will be with us. This is a course we have in March. It's a live surgery, and we'll be doing a lot of these cases on that time. And this is our 3rd annual course, and it's led by Dr. Al-Mafti, who will be the main moderator and agitator for the course. And please join us, because we need to revive this our abilities to cure these patients. It's unfair what the results that we're doing. And again, thank you, Mehmet, for the opportunity, and Sabino for managing this, and I hope we will see you all in person.
Thank you, Professor. Thank you so much. It was a tremendous lecture and a very inspirational talking. And thank you so much for your messages. As Professor Al-Mafti always say, microneurosurgery and perfect knowledge of the anatomy should be the baby milk for especially young people. So it's very inspirational talking. And I'm very, very happy personally to see how many young people are connected today. And I want to highlight the fact that also this lecture will be put on WFNS YouTube channel. So for those who didn't have the opportunity to join us, you can review this lecture on Zoom. Thank you, Professor. I don't know if we have 2 minutes more just for question, because for those who connected now, Professor told us he has an emergency case, probably will left. If we have 2 minutes.
Sabino, we can accept some questions who have been asked already.
Yeah.
To Professor Kirish. Please ask them on the chat.
Okay, from the chat, I read just one question. If you agree, I think, Professor, before you leave the stage. Okay. Now, what is the Mehmet Secher ask? What is the appropriate approach or algorithm for post-operative management of craniopharyngioma seeding surgical corridor? It's not so clear question, but anyway, if we intended the post-operative management, probably the next 2 lectures will focus on this topic. So I have a question for Professor Krish, just the only one before he leaves. What about, Professor, for pure intraventricular meningioma? There is a space sometimes for anterior interhemispheric transcallosal when they are pure intraventricular, I mean, as the second case you showed us.
Yes, I think it makes sense anatomically, and to get there, the only thing is, for me, is the real attachment of this tumor is in its most inferior part because it arises from the stalk area. And when you come from the interhemispheric approach, by the time you get to the deeper part, the anatomic connections and with the stalk may not be as easy. The difference is when you're operating from the approach I showed, you see exactly where the stalk is, and you see the relationship where the tumor attaches to it. That's on one. And as a policy of approaching tumors, it's always safer when you start from where the tumor grows and explodes out to implode it in. Just like when you are operating, for example, on a meningioma. If the meningioma fungated out and it's pushing against structures, it makes sense to go to its origin. You take the blood supply, you decompress the tumor, and you bring it away from the normal in a way. So it just makes sense. Plus, when you are at the hypothalamic region, you're going to be able to start very early to find the plane and then follow it. And that's an example. Now, if the tumor is small and you go from the interhemispheric, another thing is you may not find a wide opening into the third ventricle if the foramen is not widened. The other thing is, anytime you're operating through the ventricular system, you are carrying some risk for injury to the surrounding structures. Here, all what you're doing is really working on the tumor. And these tumors, intraventricular ones, are really not attached to the wall. You know, if somebody says they are attached, then I'm going to say, well, maybe in Arkansas they're not attached. That doesn't make sense. If I can find them attached because it's always a plane, because they really grow from one spot and just push against the wall of the ventricle from inside. And once you decompress them, it's easy to pull them out. There is no adhesions. When there are adhesions, it's a different tumor. I had a tumor which has adhesions. It turned out to be a glioma, and it looked like a craniopharyngioma. And during the case, I kept saying, this is not a craniopharyngioma, unless I am wrong again or something. And it was not. So, but, you know, you have to keep in mind a surgeon with a good sense will always do a good operation, you know. But what is achievable at its best is going to be dictated by the anatomy of the pathology. That's how I approach it.
Thank you, Professor. Thank you so much. Thank you once again. We have no more questions. I promised yesterday we were with Professor Zileli in Cairo. We just left a few hours ago, and I promised to some young people to ask you just a question, but you practically already replied with your lecture. What's the best way to take the, you know, to win the fear in approaching your first craniopharyngioma surgery, you know, for young people, I mean? What's your advice? You practically already reply anatomy, but I want to stress this concept, you know, because it's the session for Young Neurosurgeon World Federation Committee, and this is the last question. Thank you, Professor, in advance.
All our fear in what we do comes from our ill preparedness. When you are not ready, I always advise you have to finish the operation in your head before you start. If you cannot, you're not ready. You have not only, when I say you have to finish it, it means not only for the best case scenario, you are prepared for the worst case scenario. It needs preparedness. You know, I always tell young people, know your limits, but have no limits. You know, just work long term. Go watch people who are comfortable doing it. Go learn the anatomy, and not one time, don't go once and you look at it and you say, oh, okay, I see what it was. Because a highly expert person can make difficult thing look easy and you don't know where the difficulties are. You have to live and breathe that operation with somebody who has mastered it and knows how to do it. I am still learning craniopharyngioma, and I feel comfortable with it, but still, I can tell you, every case is a learning case for me. But this applies not only to craniopharyngioma, to everything we do. Do not go to an operation if you're nervous because you're not prepared. Go prepared in alertness, be heightened alertness. But if you're anxious and you feel like you're afraid and you're not sure what you're going to encounter, no. And like I said, follow that important sentence. I said, do not go hoping that your operation will be easy. Go to make your operation easy. You have to be prepared to make the operation easy. If you don't have that sense, you're not ready. And please work long term. Please, nobody listen to this steep learning curve phrase. Somebody created it and everybody lives with it. No, everything we do has a steep curve if you don't want to do it at its best. But learning is a lifetime experience. Enjoy neurosurgery. If you don't enjoy it, find something else.
Thank you, Professor. These are golden advices for all of us. Thank you. Thank you very much for once again for joining us.
Thank
okay,
you.
Now I will leave the stage to my colleague, Dr. Raghunath Kandasamy, that will introduce Professor Peter Selchuk.
Thank you, Sabino. We heard some really good lecture from Dr. Ali, who's reaffirmed the importance of anatomy and going for subtotal resection. However, in the current era where adjuvant therapy is becoming more and more prominent, we need to understand the role of, when do we use radiosurgery and, the timing of surgery. I think these are very important things. So without further ado, I would like to introduce our next speaker, Dr. Pakar Selçuk from Turkey, who will talk about the timing as well of optimal timing of surgery as well as radiosurgery. Over to you.
Thank you so much. And I would like to thank so much to Dr. Zileli for inviting me to this webinar and talk with the experienced leaders in this subject. So I will try to share my slides. Is it okay? Can you see the slides right now?
Yes, we can see the slides.
Perfect. Okay, so I will talk about the optimal timing and the role of radiosurgery or stereotactic radiotherapy for craniopharyngiomas. Sorry. So, of course, gross total resection is aim in the treatment of craniopharyngioma. But the surgery today, what we do in surgery for craniopharyngioma does not look like what our ancestors did 50 years ago. So the neuroanatomy knowledge is improved, neuronavigation improved, surgical techniques improved, surgical ways improved, a lot of things are improved. So the results of gross total resection in those patients does not look like what we had many, many years ago. So to get the cure of the tumor, from the tumor for the patient, of course, gross total resection is number one in these patients or in these tumors. However, if the tumor adherent to the optic nerves, chiasm, hypothalamus, other structures in the head, the results with subtotal resection about visual, hormonal, emotional features are better. And the quality of life is better with subtotal resection in those patients. So we should not be afraid of subtotal resection. The quality of life is the most important thing for us, not the MR after the surgery. So we can use radiation as an adjuvant treatment in these patients, and we can use fractionated radiotherapy with photons or protons, and we can do stereotactic radiosurgery, stereotactic radiotherapy for these tumors. For the gross total resection, from the articles, from the literature, we know that almost 20%, 25% of the gross total resection patients, tumors, may show recurrence. In most of them, the recurrence is due to the infiltration of the tumor into the neighboring neural tissue. In the surgery, you may think that I have already took everything out. And when you see the MR, everything is out. There is nothing left there. But when you check all the areas histopathologically, of course, you cannot do it, but you will see some infiltration, and this infiltration may cause recurrence of the tumor, and we already know it from the articles since many years. So this is a nice article, shows us that, of course, there are not so many patients, but it shows us that, please look at this graph here. So if a patient has subtotal resection, the progression-free survival drops down very easily, very quickly. If a patient has gross total resection, it is nicer than subtotal resection, of course. But if a patient has subtotal resection plus radiation, the progression-free survival is much more better than these other two. So radiation really gives some benefit for these patients. So how can we use radiation for these patients? We can use fractionated radiotherapy with photons. Photons here means X-ray. So in this article here from Aldave and the colleagues, they compared the gross total resection and partial resection with radiotherapy. And they found that if the patient has partial resection plus radiotherapy, their cognitive function and the quality of life is better than gross total resection. So for this group of patients, in their group, they operated 43 patients. Their comment is like this. So when we operate a patient with craniopharyngioma, if we have a subtotal resection and there is some residual part there, should we irradiate them immediately or later? And this article compares both arms, and they saw that if you irradiate the residual tumor without waiting for the growth of that residual part, it's better for the patient, for the progression-free survival. So our advice is not to wait after some weeks, for example, after the surgery, irradiate the residual part. Here in this article, they looked for the series with 101 patients who had photon radiation therapy, radiotherapy. And the interesting thing is you can see here that they give 5 millimeter to 1 centimeter CTV margin. It's a huge margin. In radiosurgery, you don't do this. But in radiotherapy, they did this. So it means that, can you imagine 1 centimeter of normal hypothalamus, normal temporal lobe, etc., frontal lobe received radiation. So they found that IQ is lower in the follow-up in those patients if they are treated in younger age and if the patient has high doses to the hippocampus and the temporal lobe. And of course, IQ is very important for the quality of life of the patients. And they found that if the patient is treated for the growth hormone deficiency, they respond well to the treatment in this series. And if the patient has impaired baseline vision, also they have bad outcome. And in this article by Edmondson and his colleagues, their summary is the key points are: overall survival is excellent in children with craniopharyngioma treated with radiotherapy. So they advocate using radiotherapy. Tumor, host, and radiotherapy factors impact survival and the risk of complications, of course. And the reducing target volume margins and radiation dose exposure should be a priority. You see here, reduce target volume margins. So to do radiosurgery instead of fractionated radiotherapy would be a better option for the patient who can have this treatment, I mean radiosurgery. Sorry. So for fractionated radiotherapy, we can use protons. So there are a lot of articles about proton treatment for these patients. And you see here, this is a large series with 77 patients, and they checked the results of the series, and they say that the late toxicity in these patients, you can see moya-moya syndrome in 13%, visual impairment in 40%, and endocrine deficiency requiring hormone replacement in more than 90% of the patients. So huge side effects of radiation in those patients. And this article compared photon and proton, and they checked for different issues: overall survival, progression-free survival, radiation necrosis, vasculopathy, vision, etc. Which one is better, photon or proton? And they found that there is no difference. So the photon and proton is almost same. So there are a lot of proton centers, particle therapy centers in the world, and most of them in the United States, you can see in these charts. In Turkey, we don't have any particle therapy center yet, but there are a lot of particle therapy centers in the world, and it's exploding a lot of in the latest years. But in this comment, Grossman and Kosmin said that to do proton therapy for craniopharyngiomas, does it worth the expense? Because you know that proton therapy is very expensive. And their comment is saying that radiosurgery using platforms such as CyberKnife or Gamma Knife, etc., can be enough for these patients. This doesn't worth for those expense. So this is an interesting series. I want to show it to you all. And this is a small series, of course, with 13 patients. They didn't do any surgery for those patients, for those pediatric patients. They give radiation with proton. You see here the proton treatment for these patients. And they found 5 years progression-free survival, 100%, and 10 years, 75%. But I think this can be used in a very, very selected cases with craniopharyngioma. So when we come to stereotactic radiosurgery and stereotactic radiotherapy, you can find a lot of articles in the literature about this. Most of the articles are belong to Gamma Knife series. And there are, of course, some articles about CyberKnife and our Linux-based systems. But here, in this article from Japan, they also reviewed the literature, and they found that their 3, 5, and 10-year overall survival rate with Gamma Knife were 95%, 92%, and 82%. But if you check for the progression-free survival, it is 73, 62, and 46. So it means that if you wait a lot, you will see a recurrence in those tumors. And the rate of the radiation-induced complication was in this series was 6%. But when we are talking about the recurrence after radiosurgery, we should think about this. Is that recurrence from the irradiated area, or is that recurrence from the other side of the surgical bed? That's very important, because with radiosurgery, you only irradiate the residual tumor there. You don't irradiate the other areas of the surgical bed. So if you see a recurrence in the other areas of the surgical bed, it doesn't mean a recurrence of tumor after radiosurgery. This is a almost natural history of the tumor. In this article, the authors checked for the body mass index after radiotherapy and radiosurgery, and they found that radiotherapy patients become more obese because you do give more radiation to the hypothalamic structures, so those may cause obesity in these patients. So to have this kind of obesity, of course, makes the quality of life less in those patients. In this table, you will see the comparison of the two techniques. In the first part, you see here the radiotherapy, okay, external beam radiotherapy, and here radiosurgery. The success rate, the tumor control rate, almost same, not so much difference. But when you check the morbidity, the radiotherapy series have high morbidity than the radiosurgery series. So the message should be for us is, if a patient's residual tumor is a good candidate for radiosurgery, do radiosurgery. Don't do all area radiotherapy, because you can repeat radiosurgery for the tumors which are recurring in the other parts of the surgical bed. Yes, and about the doses, of course, some of the friends here are experienced with radiosurgery. We try to give around 12 to 14 gray, 15 gray for those patients, and we try to keep more than 12 gray. Of course, if the tumor is very close to optic nerve or chiasm, etc., sometimes we keep the doses less than 12, but every time we try to give more than 12 gray for these patients. So about the complication, of course, same thing. The marginal dose, maximum dose are important. Of course, if you give very high, for example, 17 gray, 18 gray to a craniopharyngioma, you may see a lot of complication related to this, related to that high radiation. So in this article by Losa and colleagues, they compared 1 session gamma knife radiosurgery with 3 sessions of gamma knife radiosurgery. You can see here that the 3-session, multi-session gamma knife radiosurgery patients, they have larger tumors than the single fraction, single session gamma knife radiosurgery. But they didn't find any difference in the results about the success, I mean the tumoral growth control rate, about the complication. And they say that they commented you can use both of them. But in our experience, if the tumor is not very close to optic nerve or chiasm, we try to do it with single fraction. But if the tumor is very close to optic apparatus, we do use multi-session treatment. And as I said, that there are some series in this about cyberknife treatment, and the results are almost same with the gamma knife series. So with cyberknife also you can use radiosurgery for these residual or sometimes recurrent tumors. And in this article, they search for the SRS and the fractionated stereotactic radiotherapy, and they didn't use huge amount of margin for the CTV. They only use maximum 1 millimeter of CTV. So there is no difference between SRS and fractional radiotherapy in this small series. We also published our results with hypofractionated gamma knife radiosurgery for residual or recurrent craniopharyngiomas. There were 24 patients, and our 2-year progression-free survival rate is 81%, and 4-year it is 61%. when you check the literature, you will see the results about same. So you can use, but of course you should, and also the patient should know that we can see the recurrence after the treatment. But where is the recurrence? That's the important thing. I will show you some examples from our patients. This is a 43-year-old male. He had one transfemoral surgery, and there is a residual tumor there, 1.5 cubic centimeters, and we gave 15 gray to this tumor because it's very far away from the optic nerve. It is for us, for radiosurgery, it is far away from the optic nerve. So the 30-month follow-up MR image shows complete resolution of the tumor. And in this patient with 32-year-old female patient who had 2 craniotomies for the craniopharyngioma, and she has no vision on the right side. And we gave 10 gray to the tumor to keep the chiasm and the left optic nerve healthy, because it's very important in this patient. And she responded well to this treatment. And you see here the result of 25 months follow-up MR image. Another patient with a large craniopharyngioma, you see she's a 25-year-old female with vision decrease. And because of this tumor is very close to optic nerve, chiasm, etc., we decided to give the treatment in 5 fractions, 5 consecutive days. And this is the image from the treatment day, and this is the image from the 1-year follow-up. So, and we didn't get any visual problem in this patient. And in this patient, it is also another cystic craniopharyngioma. This adult patient had craniotomy for this tumor, and there is a residual, and then growth, demonstrated the growth of the cyst here. And also he had 5 fractions of treatment with gamma knife radiosurgery, and you see here the volume of the cyst goes down in the 15th month. So in our experience, and in also the experience of the many centers, we can say that if we see a recurrence after radiosurgery, in almost all of the time, the recurrence is cystic, not the solid part of the tumor, the cystic part. So like in this patient, you see a cystic recurrence on the left side of the supracellular area. Of course, you have to decide about to do a second radiosurgery, or to do a fractionated radiotherapy, or to do a surgery, or implant Ommaya reservoir. It depends on the patient's MR image. And this article, a review article, shows that you can deal with craniopharyngioma, but in every arm, you may need a radiation. So in every arm, you may need a radiation. So we have to use the proper one, and with the experienced hands, of course. And this is an overall summary of the this presentation you see here. Please look at that. You do see a lot of lines here in this graphic, and subtotal resection plus radiotherapy gives more cumulative survival rate when you compare with the other ones. So for the conclusion, I would say that, of course, our aim is to gross total resection. There's no question about it. But we shouldn't push for gross total resection. Subtotal resection is also acceptable. And with subtotal resection, radiation treatment should be done after surgery in a few weeks. Don't wait for many months or years. Single session for small tumors we do use. If the tumor is larger, and if the tumor is closer to optic nerve, chiasm, etc., we use hypofractionated treatment. But if a patient has a large tumor, and if I cannot see properly the optic nerve or the chiasm in the MR image, then we advise to have fractionated radiotherapy, because I don't see where the optic nerve is, I cannot keep it healthy. So we use fractured radiotherapy for them. And in a very small group of selected patients, you can use radiation treatment as a primary treatment. Thank you so much. So I stopped my sharing.
Please, Regunat, do you want to ask to Professor Selçuk if there are some questions from the audience? Regunat?
Can I have a comment?
Sure, Professor.
Thank you, Professor Selçuk, for your talk, and you've mentioned a lot of important points to follow, and in terms of how to plan the treatment and so forth, and especially the low dose and the attention to the optic nerve and all the different aspects of it. However, I would stress, hopefully, in the future, that if you notice, the literature is full of publications on radiotherapy, and there is very few for surgery. And unfortunately, this is because of the wrong approach that has been done historically. We should have much less people who need radiation therapy, but we have more people who end up. And in some of the pictures he showed, there's a massive amount of tumor left, and a residual should not be as big as what we've seen. And that has to be corrected in the future. A residual is like the pictures I've shown, where there is a small piece attached to the brainstem and the perforators. And in that case, we will follow it very closely. And he's right, there is more cystic components that are seen, but it doesn't mean only the cyst grow. It means the solid part grown, and then the cystic part showed up. And when you have a cystic part, you're really radiating a larger area of the tumor, and it should not be the case. You should always aspire to the smallest piece ever in this case. So I hope the future will be a different approach. And I myself think that I myself do radiosurgery, but I rarely use it. I have used it in a couple of patients, 3 patients so far. And that's how it should be. I think in the future, the neurosurgeon, who's very capable of treating a craniopharyngioma, should be the one who will plan the radiosurgical treatment, because they know how far they can do and how far they can go. And I think this is the best for the patient. This is not about, what's best for me or for the other surgeon or other doctor and so forth. Again, like I showed that picture of the train has moved, I can tell you the train has moved. The future is going to be different because we have different approaches now. We are capable of doing more for these cases. And, Dr. Selçuk showed in his conclusion, the first sentence was, don't push for gross total resection. I agree with him, don't push, but be prepared for gross total resection. And it has to be drilled in everybody's mind that hypothalamic injury and dysfunction and morbidity are caused by the ill-prepared surgeon. And I'll invite anybody to come to Little Rock. You have been here, Sabino, you've seen what we do to our patients.
Sure.
If you know what you're doing, you know the anatomy. But the problem is too many ill-prepared surgeons have jumped into doing craniopharyngiomas and ended up with catastrophes. And this is not, should be the accepted routine. We have to change it. And trust me, if any one of those of us listening, you have a loved one or yourself, that you have a problem like craniopharyngioma, and it can be resected with a great margin of safety and cured, that's the way to go.
Thank you, Professor. Thank you for this comment. And if there are no further questions from the audience.
Dr. Salsuk, maybe I'll just add something. So it's a nice flip side of things, evidence that you've shared with us. I would just like to pose one question to you. When do you think, from a radiosurgeon's perspective, when would you advocate or push, or say not push, advocate for gross total resection in a craniopharyngioma? We've seen spectrum of cases, but in your opinion, when do you go for gross total?
Craniopharyngiomas are not very frequent tumors. We do see it 1 in 1 million. For example, in Turkey, 85 million inhabitants, only 80-something craniofaryngiomas in Turkey every year. So all the neurosurgeons shouldn't need to operate craniopharyngioma. So the experience is very important. Experience is important with surgery, and also experience is very important with radiosurgery also. So if you get an education with an experienced surgeon, who performs craniopharyngioma surgery a lot, then you can understand when to push for gross total resection, when to try to get gross total resection, when not to have. You may discriminate between only the adherence of the tumor to the optic nerve or the infiltration of the optic nerve. So I would recommend to the young colleagues, as Dr. Ali said, that they should need some good experience from the good education from the experienced surgeons all over the world.
Understood. So thank you for that perspective. So, it's nice to hear both sides of the coin. Now, I think, we are inspired by both your talks. Our last speaker is someone who needs no further introduction. Dr. Paul Gardner is a name synonymous with skull-based surgery, and he's here to share his perspectives on, managing recurrences in the multi-modality setting. Paul, over to you.
Thank you. Thank you for the invitation, and congratulations for a great webinar. We've heard some very clear impressions that I think set this talk up very well. This is kind of a difficult talk to give. I sort of had to figure out how I'm going to try to simplify this concept that's very challenging, but recurrence is a very common thing in craniopharyngioma. There's no question that you can prevent this with gross total resection. There's also no question that gross total resection tends to have higher morbidity. So inevitably, there's going to be some adherence to optic pathways of the hypothalamus, which can lead to higher recurrence rates depending on the tumor. Some craniopharyngiomas are more resectable than others. Looking at our early series here, we're able to achieve gross total resection in only about half of patients, and most of the rest had near total or very rarely subtotal. Very rarely less than 90%. And here's a great example of a case where we used stock preservation. And I'll sort of skip through this in the interest of time. But here you can see opening, a typical suprasellar opening that we would use. Oh, sorry about that. This all right, you still able to see my screen okay? So typical suprasellar opening. And here you can see the opening right across the superior inner cavernous sinus, which we can coagulate and cut. And we can try to visualize which areas. One of the advantages of this, obviously, of an endonasal approach is there's no brain retraction, but also we can directly visualize the tumor and the surrounding vasculature. So here we're opening into the initial cyst wall. We can be very careful to preserve the normal superior hypophyseal vessels. And this is very much like, in some ways, acoustic neuroma surgery, where there are two arachnoid planes. If we respect those arachnoid planes, we can quite easily find the right plane with the tumor in the hypothalamus and often get a complete resection. And here you can see just dissecting that hypophyseal vessel off. And we've seen some great videos of this, so I won't spend too much time on it. But here's a beautiful example of this inner layer of the tumor against the hypothalamus. And one of the advantages I like about the endoscopic approach is the ability to see exactly where that plane is with the hypothalamus. It's really the only approach that visualizes the entire hypothalamus while you're resecting it. So here we can resect up to the floor of the third ventricle. And one of the things I want to show here is that, stalk preservation is possible. Here we're getting a pretty radical removal of all of the tumor on the hypothalamus. But at some point, to avoid transecting the stalk and trying to preserve function of a pretty thick stalk remnant here, we perhaps leave a small amount of tissue which we can't tell is inflammatory or not. So here's the post-op where we're able to preserve the stalk, and in this case, the patient preserved function as well. But it's true that preserving stalk function does increase the risk of recurrence, and so it's important to understand all of these trade-offs. And I know Dr. Krish doesn't like talking about the learning curve, but I think it's very important because all of us have a learning curve, but we have to dedicate ourselves to making sure we overcome that learning curve and stick with it. That's sort of the point of talking about it. But the more resection we get, the more pituitary dysfunction we get. They are directly sort of in counter to each other. So in trying to preserve pituitary function, we can have higher risk of recurrence. But remember, recurrence leads to loss of function. So there's a constant balance here with craniopharyngioma. So tumor recurrence in our series was seen in only about a third of cases, but the only significant factor was gross total resection. As Dr. Krish said, this is really critical, and this is with a pretty reasonable follow-up. Interestingly enough, in the patients who underwent near total or subtotal resection who had adjuvant either radiosurgery or radiation, they did not have the same lack of recurrence as gross total resection, so it did not seem to have the same benefit. Only gross total resection did. So how do we manage these recurrences when we really get to them? Well, it really depends on what kind of tumor you have, what's the prior treatment of the tumor, what symptoms does the patient have, where exactly is the recurrence, is it solid or cystic, and what's the patient's function, both of their pituitary and otherwise. Histology is very, very important when we're looking at recurrence. And that's because adamantinomatous and papillary tumors are probably very different. They're very different genetically, and they have different mutations. You can see the adamantinomatous, which is the majority of craniopharyngiomas, has this CTNNB1 mutation, whereas papillary harbor BRAF mutations. Now, BRAF inhibitor treatment, remember this only applies to papillary craniopharyngiomas, which is the minority of craniopharyngiomas. And the truth is not every papillary harbors BRAF, but about 90% of them do. So here's a recent study looking at BRAF and MEK inhibitors that was published in New England Journal. This is the group with Fred Barker. And looked at 16 patients, and you can see most of them had a reasonable response, but 3 of them progressed. This is a relatively short-term study. This is a significant chemotherapy, and 3 patients had to stop due to adverse events. And the progression-free survival at 2 years is approaching 50%. So this is not a perfect treatment, but it's a great option, I think, in recurrent tumors. Similar multi-center study done in Europe with very similar responses, and you can see discontinuation in 5 patients and well tolerated in the majority, but it is not a perfect treatment, but a great option for especially recurrent papillary tumor. When you have non-papillary tumors, though, you really have to look at, again, I think the primary drivers here are, where is the tumor? Is it causing symptoms? And then is it solid or cystic? And here's sort of a little chart I came up with for this talk. And I'll sort of go through some cases here to show examples of how this can be used. So here's a patient who previously only had this cyst treated with P32, no prior surgery. It's a recurrence. The patient's presenting with vision loss from that optic compression on the left side. So yes, it's symptomatic. Here we can see it's a combination of cystic and solid. And it's already undergone an intracystic treatment and failed that. So this patient should have a resection. Now, what approach do you choose for resection? Well, I believe in the rule of not crossing the nerve. This is how many of these approaches were developed. And craniopharyngiomas are inherently a retrochiasmatic tumor. They originate from the stalk, they originate from the hypothalamus, and they sort of herniate forward up against the chiasm. So the most, a craniotomy can be used anytime the tumor is above the optic, such as a third ventricular tumor, or when they have large cysts lateral to the nerve. But in my hands, an endoscopic approach is preferred for all, and I really believe there's some very clear advantages. So here we can see some of the advantages of endonasal approach. It's a very natural corridor. You can allow that early stalk identification, and I think it's the best visualization of the hypothalamic margin. Here's that inline corridor. It's the trying to line up your approach with the long axis of the tumor, and an endonasal approach really is the best option for this. This is that patient after P32. And here you can see the advantage. Our concern here is the margin with the chiasm and with the hypothalamus. And you can see how well we can visualize that margin. So there's no other approach that gives us this kind of visualization of the margin between the chiasm, the hypothalamus, and the tumor. So you can decide to be as aggressive or non-aggressive as you want, depending on your comfort. But you can really visualize that gliotic plane to be able to try to carefully preserve it and get a complete resection, which was done in this case without any hypothalamic injury. So what about this man? He's initially presented here. He's got a 78-year-old man with vision loss. And here you can see a significant recurrence. So again, he's someone who has symptomatic, so he's not really recurrent initially, so he should have a resection. But after resection, he eventually had a small recurrence here. You can see it impacting that right optic nerve. So this recurrence, though, was asymptomatic. So because it was asymptomatic, he was actually treated with radiosurgery to this area. Another year later, though, unfortunately, this developed vision loss due to a cyst formation within it. So as a result of symptomatic recurrence, now he underwent a repeat endonasal resection. So you can see this trade-off between the two techniques. And then now, again, 2 years later after that, he has an asymptomatic recurrence on the opposite side. So not where he had the prior resection, not where he had prior radiation. So asymptomatic recurrence, it's safe to do radiation in this location. So he underwent radiosurgery, and it was sure enough decreased 1 year later. What about these extensive cysts? I agree completely. These are really a different beast that we need to look at. So here you can see a pre-op and a post-op of a patient with a multicystic tumor. And here you can see nice pre-op and post-op, but these are very commonly recur. So here's a delayed recurrence of a cystic tumor. So again, it's cystic, it's not symptomatic. So we start looking at the radiation arm of things. And the real question here, as you saw in that prior case, is radiation or stereotactic radiosurgery safe? And what I mean by that is, what is the prior optic nerve dose? How can it be given safely based on size, given the optic nerve and optic radiation dosage? So in a case like this, it's really quite far away from the optic itself or any critical structures. It's just by the cerebellum and the CP angle. It's not even close to the cochlear nerve. And it's around the 2.5 centimeter mark. So this patient was given radiosurgery. And sure enough, you can see that patient actually managed quite well. It looks like I don't have the follow-up, but this actually decreased with time and the patient needed no other treatment. Here's another very large frontal cyst, underwent resection of the solid component, drainage of the cyst, but the cyst recurred. So how can I manage this cyst? Well, we know it's cystic. It is somewhat symptomatic, but this patient was just treated with an intracystic treatment, in this case P32, which is not really available anymore, but bleomycin can be used as well. and a very nice result for treatment, especially in pediatric patients. This is what you see commonly in these pediatric patients, that they get these giant cystic craniopharyngiomas, and you can see they essentially almost all have recurrence, and so they're managed in a variety of ways, focused on managing the cyst itself. Much higher rates of recurrence in the cystic tumors, so very significant to watch and really be more aggressive at treatment of these. Here's a recent patient I had, and this goes back to sort of approach selection as well. So here's a tumor that I thought I could get a pretty good resection of the majority of it from an endonasal approach, but you can see the tumor extending laterally. So I did both an endonasal and an eyebrow approach to try to get all of the arachnoid tumor lateral to the optic nerve, but all of the retrochiasmatic tumor from an endonasal approach. And we did preserve the stalk in this patient, although her function long-term has not held up, although she's avoided diabetes insipidus. So here I'm trying to avoid recurrence, but whatever approach is necessary should be used to get the most complete resection you can. Now here's a patient that was sent with a multiply recurrent tumor. The patient had an Ommaya, they had a shunt, they had a transventricular approach from above, they had a standard craniotomy from above. You can see the left terional, and they have an Ommaya in a cyst, and they have slow progressive, and the patient has had full dose IMRT. So it's asymptomatic, it's a growth, it's a very solid tumor. We can't really do more radiation. So this one very obviously needs at least attempt at resection. Now, people might say, well, endonasal approach is a very calcified tumor. That's not really an option. So here you can see that Ommaya, that ventricular catheter that was placed into the cyst itself. And here we just have to be persistent. So carefully working around the tumor. You can see it's very adherent to the basilar. And this tumor goes quite low. So this would be very challenging from an open transcranial approach, even going transcavernous because of how low the tumor goes. Here I'm even stabilizing the tumor and trying to drill it. By breaking it into pieces, I can manage to break the tumor apart. When you have a calcified tumor like this, there are solid components mixed in with a calcified component. Certainly radiation is not going to make a calcified tumor like this shrink. In addition, this patient has already failed radiation, which is probably not surprising. So here we can see now coming up behind the chiasm, we have a beautiful view onto the floor of the third ventricle. You can see residual solid thick tumor there, the calcified component as well. And in the end, we can break this up somewhat, but I can't really get it off of the basilar. It's too adherent. So I decide to leave a small amount of this calcified component on there. You can see it coming off of the basilar on one side, but the perforators really can't be protected with a tumor like this. Here's our final view. Resected most of the tumor, only a couple of small calcified components right on the basilar itself. And the child did quite well after this. And last I heard, he has not had a further recurrence. So I really think that this algorithm works pretty well. It may seem overly simplistic, but the truth is, if it is not symptomatic and you can safely treat it with stereotactic radiosurgery, I believe that that's a good way to approach these tumors. The risk of that is very low. I've not seen high risk of damage to any of the structures, including hypothalamus with radiosurgery. But if the tumor is symptomatic or large, or it hasn't had a good resection before, you should consider re-resection in these patients. Don't forget about the BRAF positive tumors. Bleomycin really, I think, should become first line for recurrent tumors because it may provide long-term control of these tumors once they start to recur. To summarize, craniopharyngioma recurrence, whenever possible, avoid it by getting a gross total resection. But your recurrence really has to balance between stereotactic radiosurgery, resection, and cyst treatment. And it's a constant movement between these by understanding where the recurrence is and what symptoms that might cause. Remember that recurrence will lead to loss of pituitary function. So I think it's appropriate to consider loss of function at the first surgery if gross total resection is possible. Again, want to always invite everyone for this online congress, as well as to visit us in Pittsburgh in person for the Pittsburgh course. And then I hope to see everybody at the North American Skull-Base Society, which is being done in combination with the World Federation of Skull-Base Societies, and then the European Skull-Base Society meeting in my mother's hometown of Zagreb. Hope to see everyone there, and thank you again.
Thank you, Paul. That was a very nice, insightful input on how we can, use resection as well as bleomycin and radiosurgery, you know, when we are dealing with complex recurrences. We have one question from the floor, which I'll start with. They'd like to know when would you not use an endoscopic approach? I know there's a lot of standard information in books on this, but your this.
Yeah, so I think there are a couple of cases. I've actually gone, you know, as was mentioned, the third ventricular tumors, I think traditionally I had done transcranially, but their attachment is right at the base of the hypothalamus. So if there's enough space between the optic chiasm and the pituitary gland, then I will go actually endonasally into those. And I think you can find that opening through the floor of the third ventricle, which is what you're going to come through any approach, and you can find the attachment of the tumor. And then I agree completely that higher up, the tumor is not attached to the walls. It only has one or two attachments. Once you release those, you can debulk the tumor and deliver it either endonasally or transcranially. But I would say that third ventricular tumors are good tumors for a transcranial approach. And then the tumors that really extend laterally anterior to the chiasm significantly, or especially out to the sylvian fissure. But the origin of all of these tumors really is in the stalk, in the majority of the cases. And so these extraventricular ones where it's originating in the stalk, your most direct access is endonasal.
Right, understood. Thank you for that. Sabino, would you like to bring up any questions?
Yeah, no question, just a comment. Thank you very much for giving us this very critical concept about the fact that craniopharyngioma, regardless from the technique that you use, Paul has a huge experience in endoscopic approach, but this is a curable disease. And what we should do is to push with the gross total resection. So thank you for this concept and for this message, you know, because as Professor Krish stressed and highlighted, many times this is a curable disease. Professor Krish, probably you want to add something more? Yeah, sure. Unmute yourself.
Okay. Well, thank you for this good talk. It's always good to see what you're doing, Paul, with the endoscopic approach. Every time I see it, I see you doing more and more. It's quite impressive. Just a couple of corrections. I do believe in learning curves. I don't believe in the concept of a steep learning curve. We shouldn't pay attention to how steep it is. We just have to keep working hard to achieve what's best for our patients in that sense. The other thing is, I like to just present one thing, and I mentioned it in my talk. I think that the best approach for any disease has to be tailored to what is the approach that can achieve the most in the largest number of patients. And because on one hand, you mentioned that we will not be able to see as good the plane. No, we can see the plane with the other approaches. When we come the pretemporal way down and mobilize the third nerve, you can see everything. And that's why we will be able to get more radical resection. It's true you may have a wider window with the endoscopic approach, but with the right approach, because I've heard a lot of other colleagues mention a lot of things about what you can see with the endoscope that you cannot see with the cranial approach. With the wrong cranial approach, you cannot see. With the right cranial approach, you can see enough. But at the same time, one case interested me because you're a good microsurgeon and you're doing the endoscopy, but you showed a case that you did two approaches. And the cystic one, which extended laterally.
Yeah.
And why would someone like you, who's capable of doing both, you used an eyebrow approach, which has its own limitation? This is an ideal approach to get the whole thing out. And especially the cystic component, which you mentioned about the important thing of the cystic component is to keep the cyst preserved and to go around it and take it all in one piece, because that's what decreases future recurrence. The problem is when you cut the cyst and you leave a piece and so forth. But why somebody like you would do this when I know you could have done a wider approach and remove it in one take and not have a recurrence?
Well, so that patient did not have recurrence, but the reason is simply because there was tumor that I felt was some portion was more accessible endonasally and some portion I felt was more accessible from above. And so I didn't think really either approach was ideal for a complete removal of the entire tumor. And there was portion of it that was around the optic, above the optic, and lateral to the ICA bifurcation, but then a lower down component of it behind the basilar in the stalk of the pituitary, I felt was more accessible endonasally. So I thought by using two approaches is not necessarily a bad thing, especially if you can do them in a way that allows you to get a complete removal. And that was the goal of that. And sort of the point of that slide is that we got a gross total resection, but it required two approaches. Well, I don't think there's anything wrong with using two approaches if we're trying to preserve function. I think using one approach, if it requires more manipulation, I would rather use two approaches personally than manipulate a nerve more.
Yeah, well, I hope next time you'll present one approach. Okay. Thank you, everybody.
Thank you.
All right. Thank you, everybody.
Thank you, everybody. Thank you. Thank you once again. I do believe that probably it's time to stop this session because they are ready for the next one. And once again, I want to thank you, Professor Mehmet Zileli.
I also want to express my great appreciation for very nice talks on a very difficult craniocerebral problem, a tumor. And I also thank all the participants for joining us for this wonderful panel. And now I want to ask Dr. Salman Sherif and Sandeep Vaishya to moderate the next session on management of spinal degenerative disorders.
Before we start, Mehmet, I'm going to say really this webinar was so good. I was enjoying I was there connected for the last 15 minutes and I really enjoyed it. So I'm grateful to all the speakers and I think brilliant, good discussion. I think in every way it was very good. Sandeep, you want to go first and introduce?
Yes, please.
Unmute yourself, Sandeep, please.
Yeah. Hi, everybody. So we are already 10 minutes late to start, so we'll just start it. And the first speaker would be Asim Kirazli, who will be speaking on conservative management on spinal degenerative disorders. Is the speaker here?
Yes, I'm here.
Oh, okay.
Just one moment.
You can share your screen.
You can just click the share screen button in the
Yes, I did it, but
bottom of the screen. Good, very nice.
Atamazsınız. Elinde kaldırıyorsun. Dear Chairman and dear attendants, many countries, especially developed ones, have been facing rapid population aging. As the population ages, the incidence of degenerative spinal disorders increases, and they can cause pain and disability, and also lead to secondary health issues such as cardiovascular diseases and mental health disorders. Therefore, early treatment to improve the healthy life expectancy of people is crucial. And spinal degenerative disorders coexist with other diseases. For example, sarcopenia is associated with poorer quality of life after lumbar surgeries. And the results suggest that diabetes is a predisposing factor for lumbar spine disorders. And spinal degenerative diseases and osteoporosis often coexist in the elderly. Therefore, addressing spinal disorders and some other diseases often requires a multidisciplinary approach. I would like to address the first question now. When is it possible to apply conservative treatment? North American Spine Society formed some clinical scenarios to determine the appropriate multidisciplinary treatment recommendations for degenerative spondylolisthesis. And they concluded that physical therapy was appropriate in most scenarios and most appropriate in patients with back pain and no neurological deficits. And other researchers included lumbar stenosis patients, which is the most common cause of spinal surgery in the geriatric population, and they concluded that physical therapy and rehabilitation play an important role in the treatment of lumbar stenosis. Physical therapy is the primary treatment option for patients who do not have motor muscle strength losses and incontinence and who have pain control through medications. And how is it possible to apply conservative treatment? I would like to provide you the evidence for bed rest, lumbar support belts, exercises, instrumental physical therapy modalities, manual therapy, and acupuncture. Bed rest, avoiding bed rest, and staying active are recommended all through the guidelines, even in acute low back pain. Are lumbosacral orthoses harmful? And several studies show that they are not a case of uniform deconditioning as is suspected, and they don't result in trunk muscle weakness. But as an opinion, it is better to recommend them in acute back pain and not in chronic back pain for long durations. There are lots of kinds of therapeutic exercises, such as core stability, balance, McKenzie, aerobic, aquatic, stretching, and strengthening exercises. And interestingly, in the last years, exercises such as yoga, which helps to people for well-being, are included in clinical guidelines. And there is no clear evidence of the superiority of one form of exercise training intervention over another. There are a large number of randomized controlled trials examining exercise interventions, but there is a high heterogeneity. And fortunately, no studies reported harm from exercise training interventions. As a recommendation from all guidelines, physical therapists should use exercise training interventions, including trunk muscle strengthening and endurance, multimodal exercise interventions, specific trunk muscle activation exercise, aerobic and aquatic exercise, and all general exercises for patients with chronic low back pain. TENS, transcutaneous electrical nerve stimulation, is an instrumental physical therapy agent. In a meta-analysis, which includes almost 400 randomized controlled trials, the findings suggest that it may be beneficial for pain irrespective of pain characteristics, acute or chronic, it doesn't matter, or medical diagnosis, back pain or others, it doesn't matter. Supporting the view that TENS should primarily be indicated according to symptoms. that is, the presence of pain rather than medical diagnosis. The finding supports tends to self-administer as a strong, non-painful, within or close to the site of pain, and to adjust pulse frequency, duration, and pattern to what is most comfortable. Patients are advised to administer TENS as often as necessary, and it could be used at home. A subgroup of patients with signs of nerve root compression, along with peripheralization of symptoms or a positive crossed straight leg raise test, will benefit from intermittent lumbar traction. But on the contrary, there is moderate evidence that intermittent or static lumbar traction should not be used because it will not be helpful for reducing symptoms in patients with non-radicular low back pain or in patients with chronic low back pain. Massage is a Cochrane analysis in 2015, and after that date, no randomized controlled trials for massage was performed. All kinds of low back pain had improvements in pain outcomes with massage, and also there was functional improvement, but these improvements were in short-term follow-up and only minor adverse effects. Manipulation and mobilization as manipulative therapies may be used in acute and chronic lumbar pain, but they only provide short-term improvement up to 6 weeks. There is evidence for acupuncture, moderate evidence. Acupuncture could be used in patients with acute and chronic low back pain, and significant effects were demonstrated with respect to pain intensity, but not function. There were only minor adverse effects with acupuncture. According to American College of Physicians, there was this recommendation. For patients with chronic low back pain, clinicians and patients should initially select non-pharmacological treatment with exercise, multidisciplinary rehabilitation, acupuncture, mindfulness-based stress reduction, Tai Chi exercises, yoga, motor control exercise, progressive relaxation, low-level laser therapy, cognitive behavioral therapy, and manipulation. And Zhu tried to perform a global comparison to identify and compare the recommendations of recent clinical practice guidelines. A total of 22 clinical practice guidelines met the inclusion criteria, and they were of middle and high methodological quality. If we look at the commonality of recommendations for chronic low back pain, blue lines show the agreement between the clinical guidelines, red disagreement, and purple means not mentioned. And we see that bed rest is prohibited during the clinical practice guidelines. Staying active, the blue line is high, and the other blue lines which are high is for the therapeutic exercise, cognitive behavioral therapy. And if you look at physical therapy agents, which are heat therapies and analgesic stimulation, we see that it is purple. That means there are not enough studies, randomized control studies.
Hello, guys.
Oh, I was thinking that it was my screen. I was
Yeah.
checking my connection. So
He's trying to reconnect because she had a problem in connection, probably. She called me.
Okay.
If not, we can proceed with the others.
Yeah, I think Wilco is waiting patiently. I can see him. Hi, Wilco. Good to see you.
Hello. Well,
Wilco?
maybe she can reconnect and then she can proceed because it was a nice presentation.
Yeah. She was before the end of the slides, she says.
Good to see you, Andres. How are you?
All well. Thank
What
you.
is that? What is that scenery at the back? What have you got?
That's the Edinburgh Castle.
Ah,
This
good for you.
is his backyard.
Yes.
somewhere. So if he walks out of the garden, he goes to the
Wilco has been
castle.
I know. Mehmet, what do you say?
Andreas,
Shall
welcome. Andreas,
Thank you, Mehmet. How are you?
how are you? Good to see you.
You too. You
Good to
too.
see you all.
It was a very nice presentation. We should hopefully reconnect with a colleague.
So maybe, how about if we proceed and when she comes back, then she can restart from there? Because I think the time is too short.
Yeah.
Who wants to go first, Andreas or Wilco?
Well, I think that if Andreas goes first, because I follow Andreas with one slide.
Yes. Andreas must be first, yeah.
Okay, off you go.
So you don't want to wait for our...
We will get her back once she's back. Then we can always restart from where we were.
Okay. In that case, please let me share. Can you see?
Yep.
Okay, great. Well, thanks. First of all, thank you for the kind invitation, Mehmet. A pleasure to join you online, and congratulations on the great series of educational webinars. You asked me to talk about some aspects of degenerative listhesis and stenosis. Do we decompress? Do we fix? And just to clarify, there's no conflict of interest, no financial disclosures. And I will remind us all that degenerative lumbar listhesis or spondylolisthesis is actually quite a common spinal pathology in the aging population and earlier. There is a debate because surgical treatment algorithms are still subject to controversy. There is variable evidence for decompression and fusion, which you will see in the slides as D plus F, decompression and fusion, compared to decompression alone. And on the other hand, there are several now high-quality studies which have attempted to shed light on the outcomes of both treatment strategies, and I'll discuss some of them. I'll give credit to the AO Knowledge Forum Degenerative, within which actually we're discussing this very topic, and there's a document coming out soon. But the aim of this talk is to provide a targeted short summary of the recent literature and some guarded recommendations. So the methodology behind the paper that's going to come out soon is that the steering committee of the AO Spine Knowledge Forum Degenerative selected 6 key articles. 3 were RCTs, 2 were meta-analysis, and 1 was a cohort study with radiographic analysis. I will dive into the series that we all know. So there's the trials that we all know. The first pair, in fact, was in 2016. So it's been already quite some time since this paper came out from the Boston group. And I will not go into too much detail because we will have time for discussion. But the critique of this is that while this study shows some benefits of decompression and fusion over decompression alone for stable grade 1 listhesis, it came with some important caveats. Decompression and fusion carried a significantly higher morbidity than decompression alone, and decompression and fusion may not necessarily be a good option for comorbid patients. In that trial, the surgeons performed a traditional complete laminectomy with partial medial facetectomies. And currently, it has not been studied whether a less invasive midline sparing technique, such as a laminotomy or bilateral foraminotomies instead of a total laminectomy, could have resulted or may result in lower reoperation rates in the decompression alone option. Thirdly, while the overall reoperation rate for fusion patients was lower, the revisions occur at the adjacent level, again propagating the cycle of adjacent level degeneration and disease. But overall, again, despite the investment in several trials and money, we still need more work to try and home in into the specific surgical factors that can influence the outcomes of either option, so that surgeons would ideally only offer fusion to those who would otherwise develop postoperative instability. So to summarize that paper, the quality of evidence seems to be moderate, even though it's an RCT in a very high impact journal. And it provides a conditional recommendation that compared to laminectomy alone, fusion may be considered in patients with grade 1 sleep for improved physical function. Of note, in each arm, there was about 66 patients. The next article came back to the other one. It is a European study, Scandinavian study, with about 230 or so patients in each arm, addressing a very similar question in a slightly different fashion. This was a heterogeneous patient population. It included patients with and without listhesis. They all had stenosis, but not all had listhesis. The surgical interventions were not standardized. There remained uncertainty about the presence of dynamic instability of foraminal stenosis. This is not clarified in the manuscript. And this study did not fully elucidate the appropriate indications for decompression alone, and the additional morbidity of a fusion may be appropriate for selected patients in whom post-op instability is likely. So that paper was just to have, again, moderate evidence with a conditional recommendation that those with spinal stenosis with mainly leg pain can undergo a midline sparing decompression surgery and avoid fusion. But also, of course, it showed that both decompression and decompression with fusion are options for those with degenerative listhesis. Now, there is another very interesting study, again from Scandinavia and more recent. This is the Nordsten trial. And in this particular trial, decompression alone was found to be non-inferior to decompression and fusion, with the primary outcome measure of the ODI reduction at 2 years post-op. The extra strength of this trial is that in last summer in the British Medical Journal, there was the publication of the 5-year results with similar outcomes. In other words, the reported non-inferiority of decompression alone was maintained at 5 years. There was a trend towards improved back pain improvement in the fusion group, which requires further investigation. But overall, the quality of evidence seems to be high in this particular study. And it again gives a conditional recommendation that for those patients with stenosis plus claudication, or indeed radicular symptoms in the presence of listhesis, 3 millimeters on standing radiographs, and midline sparing decompression alone can be given as the first choice. Now, there's a couple more studies to discuss, and this one is a meta-analysis from only last year, decompression alone versus decompression with fusion in stenosis with listhesis. And this systematic review meta-analysis indicated no differences in terms of functional, pain, and clinical outcomes between decompression alone versus decompression and fusion in those with low-grade listhesis at 2 years of follow-up. In addition, decompression alone was associated with reduced blood loss, reduced length of stay, and reduced complications. But on the other hand, the decompression and fusion group was seen to be able to halt the compression of listhesis, and the systematic review found higher rates of post-operative instability in those that had only a decompression. The assessment of the quality of evidence on this was low, and again with a conditional recommendation that the compression alone be considered non-inferior to decompression with fusion as a treatment option for low-grade listhesis with stenosis. However, given the higher progression of listhesis observed in the decompression alone group, it is advised that fusion is considered in those with signs of pre-op instability. There is another meta-analysis, and we all know that we have many systematic reviews, many meta-analyses looking at the same data and not necessarily coming to the same conclusion. So we're going to compare now a different systematic review meta-analysis. This is again from last year, and the quality of this systematic review is primarily affected by the inclusion of level 4 retrospective cohort studies, in contrast to the previous one, which included only prospective studies. This last one does not clearly differentiate the cause of higher baseline disability in the decompression and fusion cohort. Therefore, it's difficult to generalize its findings. Ideally, fusions would be offered only to those patients for whom the higher morbidity of the fusion operation is justified. Therefore, determining the factors behind that disability, it is still a critical element, which is still indeed needed to be better identified, and therefore it can better inform us in our decision making. The findings support decompression and fusion being offered to those with degenerative listhesis, especially those with greater baseline disability. The quality of the evidence of this meta-analysis was low. Again, a conditional recommendation that both decompression and decompression and fusion are equally considered in those for degenerative listhesis in most patients, but taking care to offer fusion to those with greater baseline disability and back pain. And finally, to throw into the mix the radiographic and radiological data and considerations. We looked at the radiographic predictors of delayed instability after a decompression alone without fusion in those with grade 1 slip. It is now a 10-year-old paper, and this one was a level 4 retrospective study, which showed that significant risk factors for reoperation after decompression alone were the presence of segmental motion more than 1.25 millimeters, a disc height more than 6.5 millimeters, and a facet angle of more than 50 degrees. We often hear these considerations, but they've never actually been studied within the contents of a randomized controlled trial. However, in this particular series, the presence of all those 3 radiographic parameters led to a 75% reoperation rate, whereas the presence of only one parameter resulted in a reoperation rate of 40 to 55% approximately. However, small sample size, non-standardized outcomes, therefore generalizability is limited. Again, quality of the evidence seems low, recommendation is conditional, but we do now again find that evaluation of radiographic parameters can aid surgeons determining when to add fusion to a planned decompression for degenerative listhesis. So in the next 2 slides, I'll summarize or discuss rather the summarizing recommendations and findings from these high quality or high impact papers. From the 3 RCTs, they each report similar results in terms of ODI outcomes. There was no difference at final follow-up between decompression and fusion and decompression alone across any of the studies. The North American or SLIP trial used SF36 as its primary outcome measure and reported better improvement in the fusion group, but SF36 was not commonly used in the European RCTs, the Scandinavian ones. The studies do differ in their reporting of the index level reoperation rates. The SLIP and the Northern trials report higher reoperation rates in the decompression alone. The Swedish study reported no difference. And indeed, surgical techniques were not standardized across the studies, with a variable use of midline sparing decompressive techniques, which confounds some of the comparisons. Again, remember, all these were published in the New England Journal of Medicine. How about the two meta-analyses? They also include some contradictory conclusions, but the magnitude of functional improvement was reported to be higher in those who had undergone decompression with fusion. Now, given the mixed results of these recent RCTs and meta-analyses, there's no an all-encompassing single conclusion regarding the efficacy of one surgical technique versus the other. It is clear that decompression alone is appropriate in many patients. It is equally clear that there is a subset of patients with listhesis in whom decompression alone would probably lead to instability or enhance disability and thus reoperation. Again, we need to recognize caveats. Are randomized controlled trials providing conclusions which are representative in all healthcare systems? Are there limiting or influential factors in the socialized healthcare system of the European trials, where there was a fixed salary, versus the setting of RCTs in the North American, where doctors have fee for service? And finally, when we consider inclusion and exclusion criteria, how representative do they render the RCT setup with respect to everyday practice? So to summarize everything, both decompression alone and decompression with fusion can be considered in the surgical management of degenerative lumbar spondylolisthesis. Precisely determining what patients require decompression alone or decompression plus fusion is not yet fully clarified. I would argue that instability continues to be the elusive term to many people and is a source of confusion. Possible clinical and radiographic parameters for evaluating this risk have been proposed, but there has been no definitive proof and no definitive RCT assessments, to my knowledge. And again, future research will have to shed light on specific patient, specific imaging, and specific technical factors as to postoperative instability, so that hopefully in the future we can choose to offer fusions in those where the additional risk and the additional mobility is justified. So I'll thank you for your attention. I would like to acknowledge the AO Knowledge Forum Degenerative and Christopher Martin in particular from Minnesota. And I'll stop there. Thank you again.
Thank you, Andres. I think brilliant talk. Enjoyed that. I think nearly everybody is saying the same thing, that we don't have enough evidence out there. And unfortunately, despite knowing what we need to do, we haven't done that over the years. But that's how doctors are anyway, I think. And we look at the results depending on, if you're a surgeon, if you're a physiotherapist, or if you are, somebody else. So everybody looks at their own perspective. There's a question from Dr. Harshad Parekh, and he's asking, what's your recommendation for fusion versus non-fusion if there's no instability on radiology but listhesis?
Yeah, so exactly. So what is the actual practice? In my practice, if someone is elderly and there's only a grade 1 slip without dynamic instability, I will do a decompression alone. If there is instability of 4 millimeters or more, if there's a high disc, and if there's again that facet orientation that worries me, I will have to think twice. But to keep things simple, if there's no dynamic instability, if it's grade 1, and especially in the elderly, there is plenty of evidence to let us do a decompression alone.
Sandeep, you want to take this question, please?
Yeah. So in my practice, we have gradually moved away from fusing almost, like, I'll not say everybody, but our fusion rate was almost 80% in degenerative spine. And now gradually we have moved away from it, and more often we are doing just decompression alone. So I was just looking at the data of last 5 years. So we had done 1,600 decompressions alone for canal stenosis and grade 1 listhesis, as compared to less than, I think, less than 300 fusions. So previously, it was just the reverse. It's 8-9 years ago. So gradually, we are moving away from fusions to decompression alone. And we have had pretty good results, and our reoperation rate is really low. But I must say that long-term satisfaction rates and pain rates were better in those patients who had decompression infusion as compared to some patients of decompression alone who continue to complain of pain, but their MRI doesn't suggest any need for reoperation. So the reoperation rate is low, but still some patients are not satisfied. So I'm still not 100% sure what to do in which patient. So we choose each patient independently.
I would agree. It's all about personalized care, and the treating physician who has the patient in front of them should be the best person to judge the pros and cons of either option. I see there a question about
dynamic fusion.
Yeah, dynamic fusion systems. Is there any convincing indication? Well, I do have some experience with the dynamic stabilization using the Cosmic system by Ulrich Medical, and taking a step back, it's fair to say that there are different types of dynamic fusion systems. Some of them are pedicle screw based, like the one I'm referring to, and others are the so-called interspinal spaces, which in my opinion, I think are now outdated. There's plenty of evidence that those do not stand the test of time. I think the only long-term trial data that I'm aware of for dynamic fusion systems is that in the end, they slowly fuse. The proposal was that they wouldn't fully fuse, that they would hold the segment together while maintaining some motion, but in the end, they also fuse. But they haven't really become very popular, and most people I know have stopped using them. So that's all I can comment on that.
Mehmet, you have any comment on that, on dynamic fusion?
No, really. We need still some studies, high-level studies, to confirm that they have benefits of fusion.
Okay.
I would say just one thing in favor of decompression alone is that a lot of patients, particularly I'm talking about older populations, patients in their late 80s and early 90s, who are not really a very fit candidate for big surgeries. They are now coming forward to get operated. Otherwise, they would be scared of doing bigger surgeries. So we are operating a lot of patients in their 80s now.
Obviously, they're already fused, so majority of the time you don't need to worry about fusion there. So at that age, they are already fixed fused.
I agree with Salman and Sandeep that with age we get stiffness, and they may not be classically fused, but they are as good as, and the compression alone is usually more than enough, unless there is overt instability. And going back to the word instability, this is the confusing term, right? I mean, what is instability means is explained in many different ways to very different people. So I think in the elderly, there's plenty of evidence now, even if we accept or not the RCTs, there's plenty of evidence that the compression alone for grade 1 is fine.
Okay, so at least we have consensus on that. We all agree on that. That's good. Any more comment, Sandeep?
I'm just checking if there are any questions.
Dr. Parekh is also asking a question about facetal screws, as suggested by Atul Goel.
I don't have experience of facetal screws, to be honest. I haven't used them. If I'm worried about true instability, I will use pedicle screws. I don't have experience of facet screws, to be honest. Do you guys, maybe you can shed light on that if you have experience with that.
Mehmet?
I think the facetal screws are weaker in construct, and they should not be primarily used in especially in lumbar spine.
Okay. Andres, thank you. It was really nice of you to be here, and
Thank you so much. Pleasure.
Okay.
No, it's welcome.
Thank you.
Thank you.
So we proceed to my presentation, Saman, or?
Yeah, I think Sandeep has just given you a hint that you have to start,
Yeah,
but
right.
it has to be better than a hint.
Okay. So I was not posing any questions. Do you see my presentation now?
No.
Not yet.
Oh. Let's do it again. Share. And now?
Yeah,
Okay.
we can.
Now it is okay. Good.
It's okay. Do you see it clearly?
Yes.
Okay. So, well, I didn't pose questions to Andreas because I also have some remarks. And probably some of you might know that I like evidence-based surgery, but I think also society needs that. And well, I think that a lot of what we use in the degenerative lumbar spine is how our emotions are going. So for those who like to read some books outside the real medical field, this is a very good book because it is showing what we think in our brain, but also how our heart leads us sometimes to decision making in spine surgery, which might be added value to our patients, but sometimes also not so much added value. And emotions do play a role, especially if you are trained in a certain way and you cannot adopt another way. Yeah, I have quite a few conflicts of interest, which some of you know. It's important to know that the conflicts of interest outside of industry is also for the governmental grants. And if you think about governmental grants, sometimes the governments want other things than surgery. So that's a conflict of interest from my side. So Andreas also already showed you the both publications, both RCTs published in the New England Journal of Medicine. One by Professor Kokawola and the other one by Peter First from Sweden. One North American, one European. And I wrote some criticism on that because there's not real evidence to use pedicle screws in the elderly with lumbar spondylolisthesis. It's not talking about isthmic spondylolisthesis. And I received quite a lot of aggressive comments by email, which I won't share. And maybe my title talk about the superfluous surgical implant is not very nice. But the reactions were quite emotional, and I think most of them were economical, and that's important to realize. So what are the publications which the reimbursement governmental institutions use and also the insurance companies? Well, if you look at this Lancet paper, which was published already quite a year ago and a few years ago, and if you look at the costs and also the impact of lumbar problems, low back pain and degenerative spine diseases, we are quite high if you look at the leading cause. It was in 1990, it was number one. In 2013, it was still number one. And the same is true for neck pain, which we won't treat here. So it's important to realize that the outside world, not being the surgeons, are looking at us with a little bit of suspicion. And we have to be aware of that. So are we doing the right thing using our implants? And these kind of publications won't help. So if you look at this paper, which was published already quite a while ago by an analyst in 2007, you see that a lot of our publications are not that evidence-based, and more than 50% what we do, and that's in general surgery, but also medication, is not evidence-based. And if you look at what is beneficial, it's a lower group. So this is beneficial. So this is what we could do if you use instrumentation, but this is unlikely to be beneficial. And for spine surgery, lumbar fusion for low back pain in multiple level disc disease is in this range. So, and nowadays, still reimbursement is paid for, but people will look at that. So that makes us to discuss with each other, are these toys for boys or not? I don't think so. We do need our implants. So I am not holier than the Pope. I won't say that I don't use implants. I use a lot of implants, but we have to prove that we need those implants. So if you look where we need it for trauma, oncological spine surgery, deformities with neurogenic compression, and also if earlier surgery has been done and the patient is destabilized. And Andreas was already talking and thinking, what is instability? And that's a difficult question in a lot of our patients. So the only thing which we ask from our societies, we need to prove why, how, when in the timing of course of treatment in degenerative spine disease, it's added value to our patients. So if we can show it and prove it, which is already being done for quite a few implants or surgeries, then we are there. So going to the C-spine, we will never prove that this kind of reconstruction is adding value. But we all know as neurosurgeons and also orthopedic surgeons that we can never prove this. But if you go to the other side, thoracolumbar degenerative spondylolisthesis, but also degenerative scoliotic deformities, is this the right way to proceed? An elderly lady, difficult walking, is that by neurogenic claudication or weakness of the hips and upper legs? With after surgery is straight back, but on the cost of what? Well, we all know, and I showed it earlier in congresses, that this paper is read by a lot of people outside the surgical world. It's by Rick Dio, a very good epidemiologist, doing a lot of lumbar spine disease epidemiology research. And they showed that the risk of complications is 2 to 3 times higher in an odds ratio than a simple decompression in the elderly patients. So there's a rise in the United States in the amount of fusions for lumbar spinal stenosis for the same diagnosis by the insurance company declarations, that there's a rise in the use of instrumentations, and not only simple fusions, but also complex fusions, which I just showed. And with this rise, there's a rise in complication rate, not complication rate only of nerve root damage, but also about cardiopulmonary or stroke complications and mortality. So we have to be aware. So do we really need to reconstruct? I think this needs reconstruction. That's my personal way. But how about a lady of 80 years? So if you look at the X-ray, it looks terrible. So I would go for fixation. But then 80 years. And the other thing is this the good way? Is this a construct in which we are happy to do that without pedicle screws in the midspine? So it's not only does instrumentation add value, but also what is the surgical technique and what's the right way? Or should we accept that people bend forward, which is not only in Asia, but also certain parts of Europe, quite regular, and probably also in South America and Africa. So accept the change of posture. So if you look at those different kinds of surgeries and different kind of maps in the BMG paper about beneficial, for tumor surgery, it's likely to be beneficial. Depends on the prognosis. But for low back pain in degenerative scoliotic deformity, there's no evidence for that. A lot of complications, but also a lot of costs. And this one, well, it is not about the lumbar spine. This falls in the category which we don't have proof. Maybe we can show it in future, but probably we will never have evidence to do that. But we need to. So that's the reason why I'm very eager to do that, and also to ask people throughout the world to also conduct studies. So I'm now in this hospital. I'm in one of those rooms here. And this is the course venue of our university in Leiden. This course venue, and also here, is not only for the students, but also for spine surgeons who are visiting this lab on the cost of Medtronic or G&G or Nuvasive to have courses here. So within my own hospital, I try to prove there's evidence-based medicine, but the big companies are giving courses in this lab, for instance, for kyphoplasty. So then the thing is, do we always need RCTs? Well, I think we need RCTs when possible. But if you look at degenerative spine disease without instrumentation and all the RCTs which has been done, it is showing a lot of evidence. We are happy with it. We are proud that we did all those studies. But if you look at what we did show, is that even for sciatica, all those 5 RCTs, they say that discectomy might be an option. So they call it low certainty evidence. So that's the difficulty. So on one way, we think we are doing a good job the last 20 years, but on the other way, people outside our field are showing that it's low certainty evidence. So those conclusions are frustrating because I was one of the authors of one of the RCTs, but also one of the authors of this publication. And I also made mistakes, and we did make mistakes. For instance, this is a very old PSD from my country, the week back, in which we induce degenerative instability by big surgeries, large surgeries. And what we can do is this study by Claudius Tomei, in which he showed that in lumbar spinal stenosis, you can do a minimal decompression without facet joint destruction. So if you do the surgery which I was trained in The Hague, wide laminectomy including facetectomy, then you induce instrumentation. Whereas if you do this, you don't need instrumentation, like Andreas was saying. And I think that this is implemented now throughout the world in all continents to do minimal invasive decompression. This is the minimal interlaminar approach, but currently there are also endoscopic approaches. But although we are proceeding the right way, there is still something like the failed back surgery syndrome. And earlier I already said there is no other equivalent in any other medical procedure, and especially in degenerative spine disease of the lumbar spine, this is an issue. And Alf Nachemson from Sweden, the late Alf Nachemson, because he died already quite a few years ago, he warned us for that. So if you look at all the implants, and these are very old slides, that I'm doing all those implants, and I did the same in my own clinic, used all those implants, disc prosthesis, PDM, even a disc prosthesis without any evidence. We used it, even IDET, which was not an implant, but a non-evidence-based interpretation. And the fusion by an axial lift was also very popular for low back pain quite a few years ago, I think more than 10 years ago. This was something I liked. I liked this innovation. And I tried to have money to do an RCT, but the company, which was in Spain, didn't want to give the money because they said, well, I have to sell and I'm a small company and we don't need evidence, but probably the evidence will show that it won't have added value. High costs, no added value. So that was my reaction at that time. to the Spanish company, if we don't do any RCT, then stop the induction. I don't think that this will still happen again. And for low back pain, I don't see any reason to use axial lift, pedicle screws, or a disc prosthesis. At that time, we looked in Western Europe to the use of implants throughout Europe in the Western part. And you see there are differences. I don't have Eastern Europe, I don't have the worldwide data, but these are the big companies selling. And you see that there are differences. The yellow is in the medium, so that's the regular use of spinal implants. But a few countries have lower, like France, there's a lower use of implants. But these are the big companies, and in France there are also a lot of small companies. So it might not be that regular. But for instance, in my own area, Germany, Netherlands, and Belgium, and Denmark, these is the same populations. So these are the same spines. But there are huge differences. The red area is a high rate of use of spinal instrumentation, which you can explain in Switzerland and Austria because of the skiing and the winter sport, like trauma. But we don't have mountains here. And I don't think either in Denmark. So we cannot explain that by a higher rate of trauma in this area. So what is the matter here? Is that overuse of spinal implants or not? When we were discussing this slide with the governments in Europe, in Brussels, they said, well, Wilco, you have to measure with the spine community in Europe and probably worldwide with QALYs to show that expensive implants are adding value by using QALY differentiation between treatments. So you all know that one QALY is 1 year in complete health, utility 1. Well, that doesn't mean anything to our patients if you measure QALYs. But does that say something to you and myself as a doctor? Can we deal with that? Well, it's difficult, but we should, because what is happening is that in Europe, and I don't know about other continents in the world, they are looking at the cost effectiveness plan, the insurance companies and the governments. So they will look at the cost difference between one treatment versus the other treatment and to look if it is dominant and less costly. So if you have instrumented spine surgery compared to another instrumented spine surgery, and you can show that there's more effect by your surgery and it's less costly, then you are dominant. And then the reimbursement system will use that. That's the way how it works in the UK and also currently in the Netherlands. But if it is more costly and you have a difference in treatment effect, then you have to show that the more costs is worthwhile the money. If it is less effective and more costly, then we have to stop. So that's the difference which is happening. This is difficult, it's econometrics, but society and healthcare decision makers are using this currently more and more. And if not in your countries, I have to warn you, it will also come to your countries. So we have to know what's happening there. We have to understand what is happening there, but also we have to deal with that with studies. So I will show you one example, which what we did, and something I believed in. I believed in interspinous implants. And this is really true, I believed in it. So 10 to 15 years ago, I used these ones. And these are the Coflexes, but there are many. And the reason for that, it was in 2008 published in European Spine Journal by Hans-Joachim Wilke, which is a very good biomechanical engineer. A lot of you know him. And he looked at the biomechanical structures and specimens with implants of all those systems, the old Wallace system, the Diem, the X-Stop. I used the X-Stop on those years, but I was more convinced by the Coflex. So the Coflex and the X-Stop were widely paid for throughout the world and implanted in a lot of patients. We did do an RCT, and I have to be honest, Coflex was very happy to fund this RCT because, like me, they believed in their product. And what did we see in the RCT? We compared the Coflex implant with decompression alone for spinal stenosis. And there was no difference between both groups. And there were a lot of re-interventions, so resurgeries in the IPD group. If you look at Euroquals and Qualis, there's no way an IPD can be cost effective in spinal stenosis. So even if you are willing to pay 100,000 euros per Quali, you will never be cost effective. So the Coflex should not be used for spinal stenosis as an implant alone. Maybe together with the decompression, but not instead of decompression. So the golden Coflex, we call it at that time, I still have the golden Coflex here in my room. Did we really need an economic cost utility analysis to prove IPD for lumbar stenosis is not worth the money? Well, we need this because it was used quite a lot and I believed in it, but in the end it was not effective. So in the Netherlands this is stopped, but I know that in still quite a lot of countries this is used. But I would say don't use it if you have a straight spine and just do a degenerative laminectomy. Finally, is RCT the way to proceed every time? Well, not always. This study, the Fabice trial, caused me to have gray hairs. It was a lot of waste of money for this trial because it was causing emotions. People were not able to randomize. Elderly patients could not be randomized between surgeries and wait and see in spinal stenosis. So then the other way is not doing RCT, but what we do in trauma to use comparative effectiveness research by using CER. So you don't do an RCT here, but you use the real world difference, and we all treat our patients differently, and then go back and use this variation to look at differences. So going back to this case, difficult case, I wouldn't do this kind of surgery. I would do it differently. I would never use PLIF cages or XLIF cages without pedicle screws here. But if we want to prove that this adds value, then we can use comparative effectiveness research if we are not willing to randomize. I would operate a patient like this if he or she is 60, not if it's 80, but then what kind of surgery? So we have to go from evidence-based medicine to medical practice-based variation. Use that and ask people in your university to look at health services research because it's more difficult. We need the real-world data after a small study, preclinical, and go away along the time. It takes 10 to 20 years to do that. So the young spine surgeons within your group, let's do that. So do we have the answer? Prove what you add value, measure costs, and do a CEA or a CUA. Present this added value to the patients, to your peers, but also to the society. Show that you're proud that you did something like that. Be honest. Search for the evidence. And even if it is looking golden, look for the evidence. And if proven cost effective, realize reimbursements. So 100 years ago, Emery Cotman and Harvey Cushing were already saying we should compare our results. Emery Cotman wanted to have an end result hospital in 1917. He was fired for that in Boston because at that moment, money was more important than status. Thank you very much.
Thank you, Wilco. I think an awesome talk. Really enjoyed that. Sandeep, your take?
Yeah, I really loved the talk. It was pretty mesmerizing. Wilco, you really nailed it. And I really loved it. Now I really miss that you could not come to our conference in 2019 because of visa issues. I wish you did. So
thank you. Sorry for that.
yeah. No, just go ahead. If there are any questions here, I think
Andres?
good. So
Do I have questions for Wilco? Yes, I always have questions for Wilco. Wilco, we talk a lot about moving away from randomized controlled trials to comparative effectiveness research, especially for surgery. But then we always see the pressure, I don't know if it's psychological or institutional or whatever, to again do RCTs. When and how can we show that CER might be superior to RCT for certain conditions?
I think that, well, we showed it in brain trauma now, but there's still a lot of criticism now. And I think we need to try that also for lumbar spine degenerative scoliotic deformity. So where there's a lot of variation. So I think that, for instance, I see Salman, I see Sandeep, I see Mehmet, and you visually, and I know that the four of you, all you four, use different methods. I think Salman will use more minimal invasive methods because I saw some of his presentation. Sandeep will probably use other constructs. Mehmet is working in a different situation and he will probably use less instrumentation. And you live in the UK, and although you like instrumentation, it will not be reimbursed. So if you use that variation, then the only thing what we have to do, we are here with more than 60 people, to look at it critically and say, well, what do our patients with degenerative spinal disease and spinal stenosis with a deformity need? And then stick to your belief or your country and then follow the data. And if we do that, then we have better studies than Rick Dio, what he did in the United States. But we just have to have the power and maybe also in Europe, we can go to Brussels and ask for funding. And I think there is a big reason for that, because now the insurance companies pay for it, and they are not willing to pay for that in 10 to 20 years. But it will be difficult. I agree with that.
Okay, brilliant. I think I really enjoyed that. I think we must move on. There's interest of time. Mehmet is going to give his comments while he's giving the talk. So Mehmet, off you go.
Are fine. And this is my talk. Actually, this talk on the philosophy of spinal implants. Do you hear me?
Yes.
Yeah. Okay. Philosophy of spinal implants was prepared mainly by Dr. Ali Ihsan Ökten, a Turkish colleague. He is also a neurosurgeon and doing mostly spine surgery. I have to translate it to English, and then he wanted me to give the talk. I will give another point of view on what are we doing currently in spine surgery. Is it correct or not? It depends on your decision at the end. As we know, philosophy and medicine are different disciplines, but in the beginning of the civilizations, the old physicians were being interested in both of them, and it is conjugated in general because they are dealing with the human and life problems. However, the Enlightenment, which started with the Renaissance, have brought the modern medicine, and by the beginning of modern medicine, the separation of medicine and philosophy has started. This separation shifted to scientific and shifted to a more scientific and technologically focused field, and the specialization has become a necessity. So then it was the start of a fragmented medicine. There was a shift from holistic medicine to fragmented medicine. It was specialization was necessary. Even the sub-branches were created. Like today, we can specialize spine as a branch, but then spinal deformity is another sub-branch. The biggest problem today is the increasing specialization and the fact that they work without knowing each other. In 21st century robotic era, the industrial medicine has started. This process in which medicine and philosophy fell apart in the previous centuries continues more and more. Unfortunately, the age we live in is a mechanical age, and medicine has now become mechanized. As we know from the modern medicine, we remember the civilizations with the imagination about ages. And this was an aesthetic perception. Like we know old Egyptian civilization from the pyramids, and then we also know the ancient Greece with its temples. Man of the modern age, however, became a homo economicus. And the wording, I think, therefore I am, has evolved to say I consume, therefore I am. This example is from my own country. This lady had a surgery before, and now she came with new onset leg pain, and leg pain was more than back pain. You can see probably the first surgery was at L5S1 level. You can see small compression probably, even if I am not sure for that, on the L5S1 level. And such a surgery with 6 levels of fixation has been done with no benefit to patient. Spine surgery in 21st century, how will this century be mentioned in the future? The wording will be I screw, therefore I am. This box is a reflection of a removed implants of a spine surgeon. And is it the surrealist painter Frida Kahlo, who had polio disease and had a serious trauma to her spine, had got multiple surgeries in 1950s, and has kept in a whole body brace for 5 months, and has depicted pictures like this on the left, with a big column on the spine supporting her head from to the spine. If Frida Kahlo lived today, would it be like this picture on the right? Is our body a construction site? We can ask that question. And this is a construction. The aim is strengthening the columns. Yes, in deformity surgeries, we can have similarities with construction. But another question is that man's search for a new existence, is it a consumption? And spinal surgery as a cast for existence implants. The French philosopher Bourdieu mentions two types of capital. One is the economic, the other one is cultural. Cultural capital is with education. Education also enables high culture and high consumption that is an integral part of it. And we have the reasons for spinal surgery, as said by the Bourdieu. The neurosurgery community has directed neurosurgeons towards the spine with mostly unjustified statements, such as we should take care of the spine now, and we should take it back from orthopedic surgeons. And the spinal surgery has become a very attractive discipline, and then it increased in different stages. What is the relation with the consumption and aesthetics? The aesthetics is a very indispensable part of the consumer society. There is a very important relation between aesthetic and consumption that plays the wheels of the consumer society. And under the name of design differences, we are also applying aesthetic in our spinal surgery. In the continuous flow of bundles of goods, design is presented as a concept that serves the wishes of the consumer. And now we are forced to use differently designed products in each surgery. We are still changing our designs of implants. Somebody says that if you consume more, if you are able to consume more, you are more freedom. You are having more freedom. However, it can be easily noticed that a paradoxical situation emerges with the consumption and freedom. In fact, aestheticization and design efforts, which are presented as a way to liberation, ultimately become restrictive of freedom. So, what is the end of consumption? The statement is that the consumer society balances on consumption and the condemnation of consumption. There is no doubt that spine fusion stabilization and implant surgery are indicated and very effective in some patients. However, the significant increase in the indications of this type of surgery, the high financial burden, as already mentioned by other speakers, the increase in complication rates, and the increase in the reoperation rates bring to mind that some of the spine fusion surgery is not necessary or without indications. What are we doing? The question must be this. Industry medicine consequences are medicine is removed from its humanistic roots, physicians are transformed into technicians, and the holistic approach to the patient is lost. We doctors need to stay away from this or question it. And we must apply humanistic medicine. The implant is an invention of industrial medicine. It has some benefits in cases where it is indicated. However, implant use without indication is close to becoming a social problem. And how to avoid the unnecessary usage of surgery or implants? Remember, operate the patients, not the films. Remember, some degenerative diseases cure spontaneously. Make a proper patient evaluation by doing a good pain evaluation. Consider patient psychology, unrealistic expectations, or environmental problems. Change the training programs and focus more on. Do not focus more on surgical techniques, but the patient selection. So it's time to add a new spirit and philosophy to medical sciences. We have that line, holistic medicine, modern fragmented medicine. now industrial medicine. We must turn back to humanistic medicine. And implant overuse is similar to overconsumption. And I want to finish this talk on philosophy of spinal surgery with the poem of Miss Emily Dickinson. Surgeons must be very careful when they take the knife. Underneath their fine incisions stirs the culprit, the life. Thank you for listening to me.
Thank you, Mehmet. I think awesome talk as always. I think all the talks have been brilliant, and it's mind-boggling. I think what you have gone through is actually what we feel every day when we see patients every day, and they've gone through surgeries, etc., and a lot of issues, and then we just wonder, are we doing the right thing? Are we training people enough? And how we should improve to sort all this out. I think I'd let Andreas to take it from here and tell us how do we move forward. Mehmet has given us suggestions.
Thank you, Salman, and congratulations, Mehmet. It's always refreshing to see talks that take well, we often use the term helicopter view, but this is much more than that. It's, you know, the philosophical treatise of where we're going and how we evolved. So great. Well, congratulations. I think it will take a lot of effort to try and find answers to your questions. There's a lot of competing factors and conflicts of interest in our day-to-day work, which we need to resist. But yes, this is a very, very thought-provoking presentation. Congratulations to both Mehmet as well as the co-author of it. Thank you.
Wilco, what do you say about it?
Well, Mehmet, I was jealous on your talk. This is how it should work, and hopefully, when we have a physical meeting during the World Congress of Neurosurgery, there might be a session about the philosophy of our spinal implants. What I like very much is very thoughtful, and also the way we should think. So maybe I challenge you and Salman to organize something during the next World Congress about this, because that might be very it is very thoughtful and also nice to see it. Thank you, Mehmet, that you did this very good presentation together with your colleague, because this is the way we should proceed.
I think
I enjoyed it.
Excellent idea, Wilco. I think we'll definitely do that, and I'm sure you and Andres will be a part of that whatever we did, and we'll get suggestions from you. Sandeep?
Yeah, I think it was a brilliant session, and everybody enjoyed it, and I think we can wrap it up now if there are no questions.
Yeah, thanks a lot to all the speakers. Actually, we digged a bit to ask backward what we are doing currently, and to criticize ourselves, not the others. And actually, we should proceed with more philosophy, not just what the industry are trying to implement. Thanks.
Okay, good. So let's wrap up, and thank you, everybody. And as always, Mehmet, great job. I think Wilco, Andreas, all our other friends have done a brilliant job. I was also listening to the Craniopharyngiomas, and that was so cool as well. So guys, we'll meet again, and hopefully we'll get more stuff for you. Thank you, Wilco. Thank you, Andreas.
Bye.
Thank you, everybody.
Happy Christmas, everyone.
Okay, bye-bye.
All the best.
Okay, take care. Bye.
Goodbye. Goodbye, everybody.